Am I audible?
Yes, sir. Please go ahead.
Okay. We are now formally starting our showcase program of this year. Last year, we have this program with the Uttarakhand urologist about nocturia. This year topic is about adrenal diseases, both medical diagnosis, medical management, and surgical management. We are doing this program to update the knowledge about a particular subject, and we take a specific state, mainly a specific state urologist, to showcase their work also on this. So this is a very good program, and I hope this will go in depth to increase knowledge of all of us for the success of program. Thank you. Thank you very much.
May I also request Dr. Muneer Khan from the Srinagar side to give his welcome note before we start the program.
At the outside, can you hear me, please? There's echo. Yes, sir. Phone पे बोलूं? Can you hear me, please?
Now the voice is gone.
Hello. There's echo. Can you hear me, please?
Yes, now it is better. Okay.
Okay. At the outset, I thank the North Zone Executive Committee for giving this J&K UT, a chance to hold this symposium on adrenals. We'll be discussing various aspects of adrenals, adrenal gland, the excretory effect, the clinical presentations, and we'll go to the case-based discussions and the approaches for the adrenal glands. Well, we can start straight away without wasting any time. I hope.
Thank you, sir. The conveners from the program are Dr. Sajjad from the J&K side and Dr. Lalit Aggarwal from the Northern USI side, and I'll request both of them to take the proceedings from here. There are J&K, actually the meeting is being organized in a physical mode, while the rest of the North Zone members are there online through the Zoom platform. So that way we are able to have much more numbers, and the meeting is also available on the YouTube if somebody wants to simply watch it without any interaction directly. So Dr. Lalit, please take on the proceedings from here, and may I request the speakers to just keep on time so that we are able to finish at time also. Thank you.
Thanks, Rishi sir. I want to also welcome all the senior urologists, Chairman USI, Kesamurthy sir, Sanwal sir, Rishi sir, all the eminent urologists from Northern USI, from J&K. And before the outset, I want to wish कि सभी को रमजान की बहुत बहुत मुबारकें. And without wasting time, we will start a relatively ignored topic, that is contemporary issues in adrenal disorders. I want to welcome all the chairpersons for the first sessions, that is PN Dogra sir, Shivam Priyadarshi sir, Gautam Banga sir, Dr. Sanjoy Sureka sir, and Dr. Shailendra Goel. So our first section will be on diagnosis of adrenal function disorders, what a urologist must know. So I want to welcome our first speaker, Dr. Yashdeep Gupta from Department of Endocrinology, AIIMS, New Delhi. He will be delivering a talk on blood/urine tests for adrenal functional disorders and lateralization. What, when, and how. So I think without wasting the time, we all welcome Dr. Yashdeep Gupta, sir.
Many thanks, Dr. Lalit, and Same to Dr. Rishi Nair for giving me this opportunity to be a part of this meeting. So maybe I share my screen. Yeah. So is it visible?
Yes, please go ahead.
Yeah. So this is a topic which has been allotted to me, the blood and urine test for adrenal functional disorders and lateralization where required, what, when, and how. So these are the learning objectives for this talk. So we need to understand from a endocrinology perspective, what are the types or spectrum of adrenal tumors we are talking about, and then discuss briefly about each of these entity, primary hyperaldosteronism, which is like getting very common nowadays with the available screening modalities. And then all we know that pheochromocytoma, Cushing syndrome, then there's ACC, and inflammatory and malignant masses can also present as a functional disorders. So these will be the focus of my talk, and I will take all these entities one by one. So before I go to specific entities, so we need to understand the types and spectrum of adrenal tumors. So adrenal tumors are broadly classified in these 5 categories. The most common are the adenomas or the nodular hyperplasia, and primary hyperaldosteronism is one of the common functional disorders with the adenoma as a background. Then the second entity is pheochromocytoma, which again we commonly see at tertiary care settings. ACC relatively rare, but still at tertiary care settings is quite common. And then the other two entities, which are not clearly associated with functional disorders, but we need to be aware at certain occasions where they can do, like benign lesions, myelolipoma. Myelolipoma can be associated in rare instances with congenital adrenal hyperplasia also, but mostly they present as a mass effect or other complications. Then the metastasis, sarcomas, lymphomas, they are not functional from a hyper functioning point of view, but they can actually deplete the adrenal reserve and can result in adrenal insufficiency. So functional point of view, they are hypofunctional, and this also we should be aware while we encounter patients who harbor these sort of lesions. The important clinical aspect why we are discussing this is that we need to be aware that clinical presentations, patient can come with hypertension, hypokalemia, can be diagnosed with primary hyperaldosteronism. You can have a frank proximal symptoms suggestive of pheochromocytoma where you have an episodic hypertension. Then all are aware of rapidly progressive mass with Cushingoid habitus or androgenic features which can be associated with ACC, that is adrenal corticocarcinoma. And in rare instances, patient can present with isolated androgen secreting tumors where women can present with hirsutism and other virilization symptoms. But what is important to know from a urological perspective or from any specialty perspective that this is all clinical only constitutes a part of full spectrum. Most of the lesions due to the availability of imaging for multiple underlying entities. So pick up the lesions which are not frankly clinical. So they can be just a subclinical manifestation where one has some symptoms but are not frank to suggest a particular entity. And then there could be scenarios when you just investigate and you found that patient could have a pheochromocytoma, but there are no symptoms, means biochemical presentations. And in rare instances, there could be scenarios where even the tumors can be biochemically silent, but otherwise depict a functional entity. So here comes an entity which is called an adrenal incidentaloma. Adrenal incidentaloma is a lesion which is more than 1 centimeter, equal to or more than 1 centimeter in diameter, but is clinically unapparent. Means and detected on imaging performed for unrelated indications. For example, there is a patient who is undergoing imaging for appendicitis or patient undergoing some unrelated scan, and then subsequently one find that there is a lesion which is sitting in the adrenal which is 1 centimeter or more in size. That is called the adrenal incidentaloma. And adrenal incidentaloma, when you're dealing with an age group of like 5th, 6th or 7th decade, they are quite common. So you can see like one lesion in every 20 individuals, and given the magnitude of imaging that happens at this age, so most of the people will do have these lesions and coming to the urologist or the endocrinologist for workup. So what is important to know from adrenal incidentaloma, though patient may not have symptoms in majority of the cases, but 25% of this adrenal incidentalomas, which are not clinically apparent, are actually functioning tumors. So if we divide further this 25%, then 14% of the adrenal incidentalomas have functional tumors that secrete excess cortisol or aldosterone. Then 7% of this 25% can have pheochromocytomas, and 4% can have adrenal cancers or metastasis from the other lesions. So 1 out of 4 patients can harbor this functional disorders, and that is why that any lesion which is detected in on imaging, even it is not like a clinically symptomatic presentation, we need to investigate thoroughly for underlying functional adrenal disorder. So with this background, I will proceed from and take one entity at a time. So let me discuss the primary hyperaldosteronism. So there, as I briefly said, that there could be two presentation, either patient coming frankly with the underlying adrenal disorders, or patient has detected adrenal lesion and we are going on the other way around and doing a biochemical evaluation, and then seeing that whether the patient has a functional disorder or not. So if patient is coming with a clinical presentation, so this is a scenario. If we are dealing with a primary hyperaldosteronism, who need to be screened? So any hypertensive patient who has hypokalemia, either spontaneous or diuretic, 1 out of 3 patients can have underlying primary hyperaldosteronism. So these patients need to be screened further biochemically and then followed by imaging if required. Similarly, if you see a patient of a resistant hypertension, which is classically defined requirement of more than 3 drugs to control blood pressure, so 1 out of 5 patients can have primary hyperaldosteronism in such cases. The other scenarios which are not like too high but still significant clinical involvement can be seen is a moderate to severe degree of hypertension. If like systolic is more than 160, diastolic is more than 100, then one has to screen biochemically for primary hyperaldosteronism. Another indication is that patient is having a young onset hypertension that is less than 40. So these are the clinical cases which may not go directly to the urologist, but if you see a patient who have a coexistent resistant hypertension or a hypokalemia with hypertension, then there is no harm in screening, advising screening from primary hyperaldosteronism, even from a urologic perspective. But what is important from a urological perspective is adrenal incidentaloma, which has associated hypertension. So such patients can have PA, primary hyperaldosteronism, in 1 to 10% of the cases. So this is a simple slide for a urologist when to screen for primary hyperaldosteronism. If you have an adrenal incidentaloma, if patient has hypertension or hypokalemia or both, you have to screen for primary hyperaldosteronism, that is first functional disorder. If patient has no is normotensive and normokalemia, then the screening for primary hyperaldosteronism is not indicated. So this is a crux for the urologist for primary hyperaldosteronism screening. To complete this scenario, what, when, and how, what I'm supposed to talk about. So what? So if you have a clinically suspected patient or an incidentaloma without clinical manifestations, then this is a path which we take for screening. After detecting a patient who need to screen as a first step, second step is what test is required. So the first test that is required is a plasma aldosterone and renin levels. Right? Once the plasma aldosterone or renin levels crosses a certain threshold, then the third step comes the case confirmation, in which we commonly do a saline infusion test, which I will show in the next slide. So there are 4 tests available for confirmation of a disease. Aldosterone and renin ratio is a screening test. Confirmatory test is 1 out of 4, which is listed in the box number 3. And once the patient passes the confirmatory test, then we do a CT scan for a patient, typically unenhanced non-NCCT, in which we see whether the patient is having adenoma or other lesion. And once that has been done, then we proceed for the subtyping adrenal vein sampling. So this is the 4th step of approach to a patient who is suspected to have a primary hyperaldosteronism. So step 1, the main thing is that initially there was a confusion that patient is having on multiple drugs for hypertension, whether we should stop, whether we should not stop, whether we adjust or not adjust. The simple message for the urologist is that if you has a adrenal incidentaloma with hypertension or hypokalemia, there is no need to look for the medications. You can advise aldorenin levels to the patient and can refer to the endocrinologist or the medicine specialist. The second step, which is typically done at a referral situations or the from a physician, is a confirmation test. So once the patient crosses a threshold to define that PA is positive on screen, then there's a saline infusion test in which we give 500 ml of saline per hour for 4 hours. And then the samples are taken after 4 hours. And if the plasma aldosterone concentration is more than 10 or more than even 5 in certain cases, then we proceed for the third and the fourth step. In third step comes the adrenal CT. Adrenal CT would look two things. So if patient is a young patient, less than 35, and patient is having adrenal adenoma, and there is severe hyperaldosteronism or hypokalemia, then there is no need for adrenal venous sampling in such patients. On the reverse, if patient can have a underlying adrenocortical carcinoma, so if you detect a lesion which is like typically more than 4 centimeter and is having features of atypical adenoma, suggestive of possibility of adrenal corticocarcinoma, then again the adrenal venous sample is not indicated and patient has to proceed on the lines of ACC. So that is the role of CT in the flow chart for primary hyperaldosteronism. The fourth step, which is typically taken at the centers of expertise, is an adrenal venous sampling. This is very, very critical step because surgical decisions are based on a well-performed test of adrenal venous sampling, in which you have to canalize both right adrenal vein, left adrenal vein, and take samples for cortisol and this aldosterone from the adrenal veins, and then take the samples from the inferior vena cava, and then you typically see the selectivity index where you see that cannulation is successful or not successful. And then after that, the lateralization index key from where the actually the aldosterone is coming out. So these are the multiple ratios that has to be interpreted in the context of adrenal venous sampling. And it is better that these are undertaken at the specialized institute so that the surgical decisions which are based on this interpretation is correct. Step 5 is a decision. If the ratio suggests that there is a one gland which is predominantly secreting the aldosteronism, then the approach is unilateral adelectomy. Again, the key message is that if there is no lateralized, means it suggests that there is no clear-cut aldosterone coming from one single gland, then the bilateral adelectomy is not undertaken. Then the decision is for giving patient medical therapy. And in both cases, the patients are kept under follow-up because even in some patients, you do a unilateral adelectomy after 5 to 10 years, so that the gland can become functional and may require medical therapy. And in case where there is a doubtful ratios lateralization, so a repeat ABS can be taken down the line after 1 to 2 years, so that to see that whether one gland is hyperfunctional or not in such cases. So the key message is that bilateral adelectomy is not undertaken in cases of primary hyperaldosteronism. The second part is a pheochromocytoma. Pheochromocytoma, again, there are certain facts that need to be kept from a urological perspective. 1% of the patients having adrenal tumor can manifest as pheochromocytoma. Not all patients will have typical symptoms suggestive of pheochromocytoma. So clinical symptoms are seen only 30% of the pheochromocytoma. 10% of the patients can be picked up as a part of genetic screening. So 60% of the tumors which could be pheochromocytomas are incidentalomas. So one has to work for the pheochromocytoma in incidentalomas so that one doesn't miss the pheochromocytoma, because if patient is operated or undergo biopsy undiagnosed and unprepared for pheochromocytoma, there could be catastrophic crisis. And we have heard about the cases even best of the centers where workup has not been complete and the patient has landed up in crisis and even frank deaths. The second thing is that clinically, biochemically, 96% of the tumors will be secreted or clinically evident, and 4% of the tumors can still have pheochromocytoma and biochemically silent. So again, when you operate for the adrenal incidentaloma, there could be 4% possibility that it could be underlying pheochromocytoma. So anesthetists are supposed to have full drugs under their kit, so that if there is any hypertensive crisis that occur in the surgical cases, they're able to deal with. The fourth thing is that 40% of the patients can have genetic mutations. So if one has a genetic mutations, one has to screen for other associated syndromic features and family members for pheochromocytomas. Again, this is a slide which is important from a urological perspective. If you do not have means to undergo this evaluate for pheochromocytoma, so this is a flow chart. If on unenhanced NCCT, you see that the Hounsfield units is less than 10, then the possibility of pheochromocytoma is less than 0.5%. So you can skip screening for pheochromocytoma. But if it is Hounsfield units is more than 10, then one has to evaluate for the underlying pheochromocytoma in adrenal incidentalomas. So these are the clinical indications, means if resistant hypertension, classical symptoms, family history of genetic syndrome, family history of isolated pheochromocytoma or adrenal incidentaloma, or there is onset of hypertension less than 20 years. So these are the indications for screening tumors. The second part is what test is best for that. In short, the standard of screening nowadays is plasma metanephrines, which is undertaken at LCMS, that is mass spec, that is a higher sensitivity and specificity for detection of plasma metanephrines. So the urine metanephrines or the urine catecholamines are little outdated nowadays. So if available, you should prefer plasma-free metanephrines for workup. If levels are more than 2 times the upper limit, the precautions that has to be taken, that it has to be done patient in a supine position for at least 20 minutes, and the level should be more than 2 times the upper limit of normal. And these are the typical 3 tests which are included in the panels: metanephrine, plasma-free or metanephrine, and 3-methoxytyramine for screening of pheochromocytoma. This is just a slide to detect, to let you know that there is a precision medicine approach in pheochromocytoma. So there is an approach called cluster 1, cluster 2, in which means you can make out if it is a normetanephrine predominant tumor, so there could be a possibility of paraganglioma or pheochromocytoma. If it is epinephrine predominant tumors, then there could be a possibility of underlying Mann syndrome. So there is some concept of precision medicine in this thing. The third part is a Cushing syndrome. Cushing syndrome you're fairly aware about. So if you have a specific clinical symptoms, one has to proceed for the workup for the clinical Cushing syndrome. Specific features, if you see a bruising, proximal myopathy, abdominal striae, these are very specific features for the Cushing syndrome. But what is important is that most of the adrenal incidentalomas could be subclinical Cushing syndrome. So one has to do a overnight dexamethasone suppression test in all patients with adrenal incidentalomas, so that to pick whether there are subclinical or the clinical Cushing syndrome underlying. So before you undertake any test for the Cushing syndrome, first test has to be done for the serum cortisol, so that you rule out that there is no exogenous steroid intake. If the levels is less than 3 microgram per deciliter, this means that patient may be taking externally steroids and just have a Cushing features related to that, and underlying lesion may not be culprit. So once the level is more than 3 microgram per deciliter, one has to take 1 to 2 screening tests for endogenous Cushing syndrome. So from urological perspective, overnight 1 milligram dexamethasone suppression test can be advised for all patients with adrenal incidentaloma. And if it is positive, then it is better to refer to the endocrinologist for further workup of this patient. The second test, which is important after that, from a urological perspective, so the most of the tumors which will they come with to them will be like having low ACTH. So if you have a screen positive for Cushing, then the next test could be ACTH. And if it is low, then it may indicate that the patient may have adrenal lesion, which is responsible for the Cushing syndrome. A slide about adrenal corticocarcinoma and inflammatory malignant mass. So clinically, adrenal corticocarcinoma can present with a glucocorticoid, androgen, aldosterone excess, or simply by mass effects. Incidentally are picked by 40%. So 60% can clinically manifest, 40% can be clinically silent. If you have a unilateral mass, and with these features, the chances of ACC is more. In bilateral adrenal masses, the chances of ACC is less. Size is usually more than 6 centimeters. So the chances of ACC is less than 4 centimeters. HU units on unenhanced CT more than 20, again suggestive of malignancy, and less than 10 rule out ACC. Biopsy is not indicated for adrenocortical carcinoma. And once a patient has a ACC, additional screening with a steroid profile using LCMS is recommended, but not a standard of care even at the tertiary care settings. For inflammatory and malignant masses, a slide. If you have a bilateral adrenal mass, there could be a possibility of malignancy, underlying infection like tuberculosis and histoplasmosis. So not all bilateral adrenal masses have malignancies. So if there is a doubt for malignancy or infection, one can do a biopsy after ruling out adrenal pheochromocytoma. And the bilateral adrenal masses could be associated with congenital adrenal hyperplasia, which can be treated by medical therapy, and surgery is not indicated for CH, congenital adrenal hyperplasia. So again, if you have bilateral adrenal masses, these are additional workup that is required: 17-hydroxyprogesterone to rule out CH, ACTH cortisol to rule out adrenal insufficiency, because if there is a bilateral masses, there could be adrenal compromise, and biopsy is required in selected cases. So I will wrap up this presentation by showing these 3 summary slides. So if you have a patient for adrenal incidentalomas, you have to ask for signs and symptoms of adrenal hormone excess, which is like cortisol, aldosterone, androgens. These are the 3 hormones secreted by the cortex and the catecholamines from the adrenal medulla. You again have to ask for the signs and symptoms of cortical deficiency, especially with patients having bilateral adrenal masses, so that is to see whether the patient is having hypofunctional state. And if there is a bilateral masses or pheochromocytoma, so underlying genetic disorders associated with adrenal tumors has to be screened. For lab workup, all patients should undergo overnight dexamethasone suppression test. If there is a hypertension, you can advise aldosterone renin. If there is no hypertension, no hypokalemia, screening from primary hyperaldosteronism is not required. If Hounsfield units is more than 10 on NCCT, then you have to advise for plasma or urine metanephrin. Otherwise, you can skip the screening for pheochromocytoma if it is not available. And if there is a clinical suspicion of Cushing syndrome, additional tests are required. In bilateral masses, you have to do a 17-hydroxyprogesterone to rule out CH. And if there is a suspicion for, again, underlying adrenal insufficiency, especially in bilateral adrenal mets, then ACTH and cortisol has to done to rule out adrenal insufficiency. The third key message is that it is better to involve colleagues across specialties when you see the adrenal incidentaloma, because there are multiple things which can't be discussed or are like has quite a lot of depth, which are better tackled by the specialist who are working in this field like endocrinology, so that the right decision can be taken up for the patient given in the given context. So with this, I end my presentation. We'll be happy to take questions if time permits, so chairpersons allow.
It's an excellent talk by Dr. Yashdeep Gupta sir. I think we can take few questions if there are chairpersons.
Lalit, can I ask?
Yes, right.
Lalit,
Right. Yes, sir.
can
Sure,
I
sir.
ask?
Yes, sir. Sure. Please. Answer.
Yashdeep,
Yes, sir.
the initial slides about primary hyperaldosteronism, you showed such a high incidence of hyperaldosteronism in young patients. You showed 3 scenarios. You said those who have severe hypertension, which is not getting under control, young patient, and third is those who have plus minus hypokalemia. Plus minus hypokalemia is understandable. But young patients, we have such a large load of young patients and severe hypertension, but they're generally not screened. And as per your data, the chances of finding hyperaldosteronism is as high as 20%, 1 in 5. So why are we not screening?
Correctly catch that slide, sir. So basically, I had given the color coding slide. So if a urologist means has to screen at least resistant hypertension and hypokalemia, because 1 in 5 there is a possibility. So and the second thing is that in endocrine clinics we are screening for hypertension, young hypertensions. So what we are saying, we are doing so in the endocrine clinics because we have our own aldosterone renin levels which are available. So these are costly investigations. We matlab at public health level, matlab it is matlab one should actually screen, but the yield is quite low. It could be less than 5% if you screen all hypertensive patients. So
actually, 5% is reasonably high.
Yeah, but most of the patients out of that scenarios can be treated biochemically, sir, medically. So surgical candidates that will come out from that pool will be less. Ideally, we should screen every hypertension actually. Right?
Okay.
But the chances are that at least we screen the one where the yield is maximum. So in endocrine side, we screen all, but I think I will not advise for a urological perspective to give aldorenin levels to each and every patient who is having hypertension. That is the case.
Dr. Yashdeep, Dr. Shailendra,
Yes,
do you recommend for any incidentaloma if we are operating or something, so we should screen for pheochromocytoma, and now you recommend it is a plasma free metanephrines or plasma metanephrines?
Plasma
What you
free,
recommend?
plasma free, plasma free. So there are two thoughts. If patient can
Plasma.
afford, yeah,
Hmm.
if patient can afford, every patient has to get screened for pheochromocytoma, right? But in such cases, like if you don't have availability of plasma-free metanephrines, so you have to see NCCT, unenhanced HU units. If it is less than 10, the chances of pheochromocytoma is having close to 0% only, less than 0.5%. So in that cases, one can
When is
skip.
the fat containing? If it is
Otherwise,
a fat less than 10 means fat containing.
fat containing. So if it is a typical adenoma less than 4 centimeter, H unit is less than 10, test is not available, one can skip. If test is available, can make a rule that everyone has to get screened for pheochromocytoma.
And preferably plasma free
Plasma free
metanephrines.
metanephrines, yeah.
So the
Because
previously 24 hours urine metanephrine, catecholamines or normetanephrines, previously these were recommended.
yeah,
Now
so even we
it
were
is a
doing
plasma free.
plasma free metanephrines, like we have our own LCMS at AIMS, so we do plasma free metanephrines. So one that is convenient for the patient to get it collected. So pre-analytical issues are less with the plasma free metanephrines because patient may not collect properly 24-hour urine reports. So
Any
that
timing is recommended for this?
yeah, it has to be collected in a fasting state because 3-methoxytyramine, which is a part of that panel, is affected by the fasting or the non-fasting state. So one has to be fasting state and then supine for 20 minutes at least before taking a sample.
Supine, what, 20 minutes?
Supine position, matlab one has to lie down in for spine
Lie
position.
down for 20 minutes.
Yeah, because the borderline cases, like for example, if you have a 1.8 times upper limit of normal and patient gives the sample in a standing situation, it can become 2.2, which will be false positive then. So it has to be.
Okay, I think a lie. This is an important lying supine because most of the patient is coming to the hospital, they are not supine. And 20 minutes supine, how can in any hospital lab setup patient can be lying 20 minutes for the sample?
So like in AIMS, I'm not sure how other lab people will tackle, but in at AIMS, like we have a daycare center where people we have like 4 couches, so patient can just come and lie down for 20 minutes and then the nurses take the sample. Because this
Okay.
is a
No, I think
patient.
this is this was I was not knowing because prolactin I was knowing the patient has to be wake up for 2 hours, but
Okay.
lying supine for
I
20
think,
minutes. I
sir,
think this is an important thing.
we need to bind up our
No,
first
I just
talk.
want Yashdeep, just one comment.
Right.
Don't you
Yes.
think that 24 hours metanephrines would be safe from the vagaries of all these things? Like for plasma, you have to make this, and plasma metanephrines will be varying in the 24 hours, whereas 24 hours urinary collection that way will be more reliable.
No, sir.
Rather than
Sensitivity and specificity both are higher with the plasma-free metanephrines.
okay.
So there is no doubt nowadays. It's like a one standalone test, which if available has to be preferred over urinary metanephrines.
But I thought it's more amenable to all the vagaries of
It's
position,
more.
etc., etc.
It's actually more easier. So once we are
Okay.
not doing plasma-free metanephrines, it's much easier to do and accomplish this test
Okay.
for good sensitivity and specificity.
Thanks again, Dr. Yashdeep sir, for informative talk. Now we move to our next speaker, Dr. Shamim Ahmed, Department of Nuclear Medicine.
Lalit, just a minute. Are there any questions from the Srinagar Hall? Dr. Sajjad? Hello? We can't hear you. Hello? Okay, so we also have 2-3 questions in the chat box. I think we can then let the Dr. Yashdeep go. See, there are cystic masses also, which are incidental. In those cystic masses, if there are no clinical symptoms, do you still assess for functional evaluation? Yashdeep?
Again, cystic masses can be like a part of pheochromocytoma also. So we have seen the cases where patient has an underlying pheochromocytoma and due to extensive necrosis, the lesion has become cystic. So I think it is recommended that if it doesn't fit into the myelolipoma or a typical lesion, then obviously we have to screen for at least for pheochromocytoma. Dr. Rajiv has, I think, put a comment that not needed a pure classical cyst. I think if the radiologist says that definitely there is no indication for atypical adenoma, then obviously we can skip in the given scenario. But again, such cases, I think we can encounter less in our clinical setting. But obviously, yes, if radiologist says there is no harm, but HU is less than 10, there is a typical cyst, then obviously we can do so.
Okay.
Can the plasma-free metanephrine sample be transported to outstation if the patient is from a remote place? Does it remain stable?
Sir, if properly collected and transported, obviously it can be, because not all centers will have that facilities. Like this LCMS is very costly equipment at which even that outside this labs do this part. Again, but that there is a SOP that has to be followed then. Then it is better to involve the people who, like, obviously external labs will be doing that. Then follow the SOPs for transportation for that samples.
एक मिनट खोलना सर
Okay.
खोलो यार
Thank you, Dr. Yashdeep. If there are no more questions, you can stay with us for just about another 15-20 minutes. If there are
Sure.
any questions pop up, we'll ask you again. Thank you.
Sure, sir.
Okay.
Thank you.
Sir, can we call our next speaker?
Yes, please.
Yes. So this is our pleasure to call our next speaker, Dr. Shamim Ahmed for Department of Nuclear Medicine, AIMS, New Delhi. He will be delivering a talk on imaging radionuclear investigations for adrenal functional disorders. What, when, and how? So I request Dr. Shamim Ahmed to take the stage. Right.
लाइट ऑन करें can you see me?
Yes. Shamim sir, you are visible and audible clearly.
Okay, can I share my slides?
Yeah, sure.
Okay, please wait a moment. I'm sorry, it is actually not coming. Give me a moment, please. Hello.
Yes, we are waiting.
डॉक्टर नायर है ना एक्चुअली वो नहीं आ रहा है मेरा दिखा नहीं रहा है ये
शेयर वाला ऑप्शन नहीं आ रहा है सर
शेयर वाला आ रहा है स्क्रीन वाला आ रहा है डेस्कटॉप आ रहा है उसके आगे एंटायर स्क्रीन क्लिक किया उसके आगे नहीं आ रहा है डाउनलोड में है मेरी प्रेजेंटेशन एंड दैट्स नॉट कमिंग
So in a while, can we move to our next speaker, Rishi sir?
वो कर लो
Okay. ठीक है कर लो
Right. So from our second session, clinical management of adrenal disorders, we request our first speaker, Dr. Aditya Prakash Sharma from PGI Chandigarh, Department of Urology. He will be talking on updates regarding pheochromocytoma. So, Dr. Aditya, I request you to kindly start the session.
Am I audible?
Yes, you are audible. Right.
Is my screen visible right now?
No, your screen is not visible.
Just give me a second, please. I had to leave this meeting and rejoin. Just give me a second.
Okay, fine.
Yeah.
Dr. Shamim Ahmed, sir.
Is it visible now?
No, okay, fine. Dr. Aditya, it's visible now. You can please
Perfect.
start.
Perfect.
Kindly stick to your time, right?
Yeah, sure. So thank you so much at the outset, Dr. Lalit and Dr. Rishi, for giving me this opportunity. In the next 8 minutes, I'll be discussing an overview of pheochromocytoma and recent updates so that we can know what is latest in pheochromocytoma. We all know that pheochromocytomas are rare catecholamine secreting tumors. They arise from chromaffin cells of adrenal medulla, and that is why they are known as pheo, which is pertains to the brown color which comes on histopathology. And now the new terminology for these tumors are pheochromocytoma and paragangliomas, PPGL, which is they are known as. The incidence is quite low, but as a tertiary care center, we receive a lot of these cases, and I'll be discussing whatever experience we have at PGI. As far as the clinical spectrum is concerned, as Dr. Gupta also touched upon, the classical triad is present in about 50% of these patients, which is hyperhidrosis or sweating, vascular headache, and palpitations. A lot of these patients can present with atypical symptoms, and based upon what the neurotransmitter is secreted, for example, in epinephrine secreting tumors, they may present with orthostatic hypotension. Even patients who are dopamine secreting, they may be without any episodes of hypertension. And patients who are diabetics can present with worsened hyperglycemia, and so on and so forth. What is new is, as Dr. Gupta also touched upon, is the molecular classification, which divides the pheochromocytoma into 3 subtypes. And these 3 clusters, I'll just briefly touch upon. The cluster 1 is the pseudo-hypoxia type, which encompasses SDH mutations, including A, B, C, and VHL mutations. And these cluster 1 tumors are basically norepinephrine secreting tumors. The cluster 2 mutations are again neurofibromatosis or MET or RET mutations, and these are predominantly epinephrine secreting tumors. And while the cluster 3 mutations have a predominantly WNT signaling pathway mutations, and these are dopamine or non-epinephrine secreting tumors. This is important in terms of not only in the terms of tumor secreting, as well as in terms of malignant potential, because we all know that SDHB mutation leads to more of malignant potential as compared to other mutations. More importantly, you have now signaling pathway targeted drugs which are used for malignant pheochromocytoma, which I'll discuss next. So as we discussed in detail, the plasma-free metanephrine becomes the gold standard, and the patient has to be in supine for at least 20 to 30 minutes. And depending upon the cutoff levels, you diagnose it. Plasma-free metanephrine was also preferred test in children because it was cumbersome to collect the 24-hour urine per se. The clonidine suppression test is rarely used to distinguish between essential hypertension versus a pheochromocytoma. And the cross-sectional imaging, as we discussed, is the CT scan. We do gallium DOTA-TET PET CT in all the patients to rule out any multifocal disease or to look for any metastatic disease. This is a very sensitive test, and detection rate being almost 90%. If the gallium is not available, you can use a 18F FDG PET CT or a 18F DOPA PET CT to look for any multifocality. Coming to the management, the preoperative preparation starts at least 2 weeks before with the alpha blockade. And the drugs recommended are phenoxybenzamine. We use prazosin in our setup. Once the adequate alpha blockade is confirmed, you can look for nasal stuffiness and BP control. The beta blockers are started. Contrary to the essential hypertension management, these patients are also started on high salt and volume replenishment because of the volume contraction. This is the patient I operated yesterday. You can see a typical prescription of these patients, Minipres XL being a prazosin, the alpha blocker started, followed by a metoprolol, which is a beta blocker, and a calcium channel blocker. And this is the supine and sitting BP measurement, which is done, which is, you can see it's very frequently done, and sometimes it is cumbersome for the patient as well as the caregiver, but this is to be done. And once you have done all this, then you need to see whether you have optimized the patient. So this is the old criteria, which is the Roizen criteria, very, very familiar and very famously asked in exams as well. The BP should be less than 160 by 90 millimeter of mercury. There should be no orthostatic hypotension, no ST or T wave changes, and no PVCs, or PVCs if present should be less than 5. Once you have adequately optimized the pheochromocytoma patients, the intraoperatively anesthetist is one of the prime driver, and I jokingly almost say that it's the anesthetist tumor because the BP fluctuation is predominantly controlled by the anesthetist. So they should be very well conversant with judicious use of vasopressor, BP control using nitroprusides, and the infusions to be used. And invariably, arterial BP monitoring is required during surgery. Earlier, we used to use a center line as well, but now we resort to a 2 large bore IV cannulas in majority of our patients. The surgical excision is the cornerstone of management, and you should carefully look for multiple lesions in whatever imaging is available to you. The laparoscopic approach is what majority of these patients you will be able to cater to. Retroperitoscopy is preferred in selected cases, in bilateral cases, especially in centers where retroperitoscopy is done routinely. Robot-assisted approach is a newer approach which can be done for multifocal lesions, paraganglioma, especially in interaortocaval or paracaval locations, and especially in tumors on the right side, which are going way into the cranially below the liver and behind the inferior vena cava, where you think that you might be requiring suturing of the vena cava itself. Retroperitoscopy, as I mentioned, they can be done for bilateral tumors, especially in jackknife prone position, so that a single position can give you approach towards a retroperitoscopic management. Robotically, primarily in literature, they have described for larger tumors, obese patients, and complex tumors which are retrocaval, and where you contemplate that you will require suturing of the vena cava, it becomes much easier at that location. And fewer indications we also reported. For example, you are tackling simultaneously a renal mass along with the adrenal tumor. This was not, of course, a pheochromocytoma, but an incidentaloma. But these are certain indications in which robotic can be done. In bilateral cases, if you are doing laparoscopically, you can also do a cortical sparing adelectomy, but you must be sure that you have removed all the nodules, and you should carefully inspect the bed as well. You should also counsel the patient that despite your best of the efforts, he might require supplementation with corticosteroids in post-operative period. Malignant pheochromocytoma is where maximal updates have taken. Still, the definition is the presence of metastasis. Short of it, you have a lot of criteria, but you cannot diagnose a metastasis or a malignant pheochromocytoma. The conventional therapy being CVD, which is cyclophosphamide, vincristine, and dacarbazine. And now, based on the targeted therapies, you have sunitinib, cabozantinib in patients who have failed on CVD. Lutetium dotatate therapy, I think the nuclear medicine counterpart will cover, and IR part will be covered by Dr. Chandan in the next few speakers. These are few predictive models of malignancies. These are used, but you must remember that this is the combination of histological features with Ki67 or SCHB mutation status. More and more molecular diagnosis is being done, and you'll have more of these scoring system. But as of now, malignancy is diagnosed with presence of metastasis. For example, this is one case which we did in which intraoperatively we found that there is a lesion over the liver. So a careful inspection of the abdominal cavity is what warrants you and will save you and the patient. The patient is now 5 years in follow-up and is doing well. So you can see the hepatocytes as well as the cluster of pheochromocytoma, which was the diagnosis of a malignant pheochromocytoma in this case. Newer therapies include lutetium, sunitinib, and cabozantinib, which are used clinically at least now at our center, which provide good disease control rate. And you have other therapies in terms of exitinib, bisultifan, tiparifenib, and more as mutations are being taken care of, the more targeted therapies are going to come. Just a word in the last about the management of bladder pheochromocytoma, because we have a good series of these cases. You can see this tumor, which is again classically a light bulb sign on MRI, because these are vascular tumors vis-a-vis a urothelial tumor, which is also enhancing but not enhancing that much. So it can also suggest you that you are dealing with a bladder pheochromocytoma. One of the cases my resident called that BP is rising as I am trying to do it, as I am trying to resect it. So that is another indication in a young patient, you are trying to resect and the BP is rising, you are dealing with a pheochromocytoma and you have to abandon the procedure and again start on alpha and beta blockade for these patients. In a few of these patients, we have done transurethral resection, but one of the patients recurred after 5 years, came with diffuse metastasis. So from there on, we are taking a more corrective approach and doing a partial cystectomy using robotic or an open approach. So this area still needs to be seen into. So to conclude, early diagnosis is the key to prevent hypertensive crisis, as my predecessor also mentioned, can lead to very much even death in certain cases. Genetics have become crucial for risk stratification and management in pheochromocytoma. Multidisciplinary approach, including endocrinologist, your anesthetist, and yourself, are of paramount importance in these cases. And now emerging newer therapies in malignant diseases, including targeted therapies, are going to be a game changer for malignant pheochromocytoma. Thank you so much for your patient here.
Thank you, Dr. Aditya. Dr. Shamim, sir, are you ready with your slides? So can we take the questions after both of the talks?
Yes. Later.
Right. Now your slides are visible, sir.
Yes. So, good evening, everybody. Thank you very much for this opportunity, particularly Dr. Rishi Nair. And I will be talking about radionuclide investigation in adrenal functional tumors. Just give me 1 second, please. So nuclear medicine is very new to many people, and so I will give a brief introduction what is nuclear medicine and how that we do this investigation over here. Most of the radionuclide which we use in nuclear medicine we get from the cyclotron and the reactor. As we get this radiotracer, we do their labeling in radiochemistry, and followed by we inject this radiopharmaceutical into the patient, and then we acquire images on the scanners. So this is how we do the radiochemistry part in the nuclear medicine. And for therapy, we have a radionuclide, as we can see from this image below. Radionuclide are labeled with the targeting molecule with a linker, and then they will be given to the patient for the therapy purpose. That's how this therapy work. And we do scanning under SPECT CT and the PET CT. So in the role of nuclear medicine or the imaging in adrenal functional disorder is to make the diagnosis of the patient. Those are having Cushing syndrome, pheochromocytoma, primary aldosteronism, and adrenal acidoma. So imaging play an important role in diagnosis and management of these patients. There are different imaging modality which are used for the this adrenal tumors, and I can say the adrenal lesions. Starting from USG, then CT, MRI, and SPECT CT. Each one has their own advantages and disadvantage. Like CT is very quick, less costly, and higher spatial resolution, and it is used for bony invasions and extra. And MRI have high spatial resolution, and it is done for the metastatic disease workup. And SPECT CT and PET CT is done when we wanted to see the functional status of the tumor. It has high sensitivity and high specificity. So this is the first indication of the nuclear medicine investigation in adrenal tumor is, or adrenal lesion, is to differentiate between the benign and the malignant lesion. Like here we can see the upper row, there are different type of benign lesion in the adrenal. This is adrenal adenoma, and then this is water density cyst, and on the right side we can see the calcification. These all are benign tumor. But when there is any doubt on the CT or MRI or USG that particular lesion is malignant or a benign, then the nuclear medicine imaging play important role, where we have a different investigation which can be done to differentiate between a benign and a malignant lesion. Like in case you can see the images in the lower row, where we can see the bilateral adrenal lesion, right one and the left one, both are non-FDG averted. That means these tumors are benign tumor. So they need not to be treated as malignant one. On the right side, as we can see there, the tumor is showing increased metabolic activity, which suggests that this particular tumor is a malignant lesion. So PET CT and the SPECT CT images will give us an idea whether this particular tumor is a malignant or a benign one. So on the basis of that, we can decide the management of the patient. Another indication which is importantly done for the adrenal adenomas or adrenal lesions, that is MIBG scan, which previous speaker has also mentioned. It is done to differentiate between pheochromocytoma and other type of the tumor. Like here we can see this is right adrenal lesion. So on CT we can see there is a hypodense lesion. On the SPECT CT images, we can see there is no tracer concentration in this lesion. That means this particular lesion is not because of the pheochromocytoma, that will turn out to be adenoma. So that's how it will differentiate between benign, between pheochromocytoma and other type of tumors. Another example, as we can see on the right side, this is a large lesion in the right adrenal, which is also not showing MIBG concentration. That means this is again not a pheochromocytoma. So MIBG is very important investigation which can differentiate between pheochromocytoma and other type of tumor. So in pheochromocytoma, we have different type of investigation, including FDG, we have FDOPA, then we have MIBG, and then the gallium dotanoc. Which one should be used? I'm going to elaborate in next few slides. Which one should be used first and which one should be used last? I will be discussing in the next few slides. This is the imaging logarithm. As we can see, patient suspected of having pheochromocytoma, then this patient has clinical scenario, including patient having biochemical diagnosis of paraganglioma. Then patient underwent the imaging studies like CT and MRI, first imaging modalities, and then the functional imagings are done to characterize that particular lesion like gallium, FDOPA, and then the MIBG scan and different things. And in therapy, radionuclide therapy also play an important role in these days for the management, in addition to the chemotherapy, surgeries, and targeted therapies. So what should be the goal of the this imaging in these adrenal lesions? First of all, the first goal is to locate the tumor. Where is the tumor? Whether that tumor is in the adrenal or it is also present in the rest of the body also. So in this, it will assist in making the differential diagnosis. It is used after CT and MRI, and it helps us to assess the functional functional status of the tumor. It helps to detect the multifocality. More in 10 to 30% of the pheochromocytoma can be multiple and can be at the other places in the body. So it is important to know the other side of the pheochromocytomas so that the management become easier. Otherwise, if the patient is subjected to the surgery without knowing the other lesions, the patient may go into the crisis. And those have gone for the surgery and to detect the recurrence, again, there will be a lot of fibrosis at the site of surgery. So it is difficult to differentiate between the normal fibrotic tissue and the recurrence. Then the functional imaging play an important role in this type of scenario. It helps in locoregional extension, particularly to the adjacent structure, including the lymph node and extra. It detects the distance metastasis. It also assesses the feasibility to remove that particular tumor. So coming first of all, coming to the MIBG scintigraphy, as this is used for detection of catecholamine secreting tumor. It has high specificity. It has improved localization when we combine with the CT. And as we can see, upon giving this MIBG, they are localized within the neuroendocrine tumor vesicles, and from there they will emit the radiation. That radiation is detected, and that will help in making the diagnosis of that particular tumors. So there are few limitations of MIBG. MIBG was considered very highly sensitive and specificity before gallium dotanoc came into the market. And after gallium dotanoc, now the MIBG is not used as a first line of imaging modality. It is used when we have doubt, particularly on the other imaging modalities. I will tell you in the next slides where the MIBG indication is right now. And it is also used when we are planning MIBG therapy before giving MIBG therapy in pheochromocytoma patients. So patient preparation is important. It is important for the urologist also to know which drug to withdraw before sending the patient for MIBG scan, like opioid, tricyclic antidepressants, sympathomimetics, antipsychotic, central hypertensive agents need to be withdrawn before subjecting patient to the MIBG scan. So this is how the MIBG scan look like. As we can see, this was a 33-year-old male having suspected pheochromocytoma. This patient underwent MIBG scan. These are the anterior images. These are the posterior images. As we can see, there is a physiological uptake in the thyroid and the urinary bladder. In addition to this, there is a right adrenal pheochromocytoma, which is concentrating this MIBG radiotracers. And on the right side, as we can see, this patient is 55-year male having bilateral pheochromocytoma. This one is the left one. This one is the right one. These are the anterior images and these are the posterior images. And that's how the MIBG will let us know whether this patient is having any other pheochromocytoma in the rest of the body. As we can see from these images, there is no other pheochromocytoma in the rest of the body. So the surgeon is very clear that he or she is dealing with that particular tumor. This is another patient having a suspected pheochromocytoma. This patient has a left supraadrenal mass, as we can see from these images. Patient has central necrosis and peripheral tracer uptake. In addition to this, patient has a left para-aortic lymph node and the liver metastasis. So this is the imaging finding will only let you know whether this pheochromocytoma is a malignant or a benign one, because on pathology both pheochromocytoma, benign as well as malignant, both will look like same. So only the imaging modalities will tell you whether this patient is having malignant or a benign. If there is metastasis, then we can say this particular patient is having malignant pheochromocytoma. If there is the tumor is well localized to the regional side, then we can see this is a benign pheochromocytoma. So another patient having this paraganglioma with metastasis to the skull and to the chest, as we can see on the left side. This patient is having pheochromocytoma, had Mantoux syndrome. It was associated with Mantoux syndrome, and it is also used for evaluation of the Mantoux tumors to localize for other tumors sites. This patient was having a MIBG scan. This patient was operated for that, and recurrence was suspected. As we can see, there is a subdiaphragmatic lesion in right paracolic gutter region. There is a lesion which shows that this patient is having recurrence of the pheochromocytoma, metastatic pheochromocytoma. So next important investigation which is done for the pheochromocytoma is somatostatin analog, that we call gallium dotanol PET-CT. This help in localization of tumor, and it is the most of the pheochromocytoma express these somatostatin receptors, particularly type 2 receptors, and patient in this scan patient need not to undergo fasting, and the scan is done in 60 minutes. This is how the pheochromocytoma look. In this patient, as we can see, this patient has bilateral adrenal lesion. This was the left adrenal lesion, and this was the right adrenal lesion. And on the images we can see there is clearly they are showing this somatostatin receptor concentration on the left side as well as on the right side. So this patient had bilateral pheochromocytoma, which can be detected with the help of the gallium dotanol PET-CT. And next investigation is F-DOPA PET-CT. That was gallium dotanol PET-CT. Now the F-DOPA PET-CT has advantage over gallium dotanol PET-CT, particularly in pheochromocytomas, because they have a better resolution, they have a better concentration. So this is how this is the mechanism. I will not go into the detail. This is how the F-DOPA is taken within the tumor cells, and they show concentration within the tumor cells. So this is the preparation which we use for the F-DOPA patient, and this is the images look like the similar images as we can see in the gallium dotanol. This is the left adrenal lesion with periportal lymph node. So this patient has a metastatic pheochromocytoma. This is another patient having small lesion. Patient underwent F-DOPA scan. On the F-DOPA scan, as we can see, there is a small lesion in the left adrenal, which is showing this radiotracer concentration, and it will help us to detect even the smaller lesion of pheochromocytoma. Another patient underwent F-DOPA. We can see there is a mass in the right adrenal with metastasis to the lymph node. Now, next investigation which we can use in pheochromocytoma, that is FDG. FDG is not specifically used for pheochromocytoma until unless there is aggressive adrenal tumors. It helps to differentiate between adrenal malignant tumor and pheochromocytoma. And it will also help that adrenal lesion is particularly because of adrenal problem, or it may be because of the other reason like lymphoma, adrenal oncocytoma, or metastasis from the other side. That's where the FDG will help us to differentiate whether this particular tumor is because of the adrenal problem, or it may be because of the problem rest of the body, or maybe because of the other reason. This is the summary of the radiotracer which can be used for the paraganglioma, including MIBG, then FDG, F-DOPA, and gallium. These are the 4 important investigations which we use for the pheochromocytoma, and most important and most common one is the F-DOPA. If F-DOPA is not available, then we can consider for going for gallium dotanol studies. This is how the algorithm of imaging help in used in this paraganglioma and pheochromocytoma, as we can see. If the patient is having sporadic pheochromocytoma, then F-DOPA is advised. And F-DOPA is not available, then the gallium dotanol can be given. If the patient is having the hereditary paraganglioma, then SDHX mutation will be done. And if there is mutation is positive, then the gallium dotanol scan should be done. So next, this tumor of the adrenal is primary aldosteronism. In this, the nuclear medicine also play an important role. And since gold standard in this is venous sampling, because it requires specialized expertise, invasive nature of procedure, high cost. So this may not be a preferred technique in evaluating the endocrinology. So nuclear medicine imaging is non-invasive and has a wider application in diagnosis and treatment of aldosteronism. So this is the mechanism of this different radiotracer which can be used for aldosteronism, including the NP59, pentoxafor, pentoxathar, and then the metamidates. These are the different radiotracer which can be used for imaging of aldosteronism. I will not go into the detail because of the lack of the time. This is the imaging of patient having primary aldosteronism. Patient underwent this pentoxafor PET CT. As we can see, this patient has bilateral adrenal lesions. Like on the right side, this is the adrenal lesion. On the left side, we can see there is another nodule. The right one is showing uptake, while the left one is not showing. That means this is the aldosteronism. This is the culprit lesion, and this is not the culprit lesion. On resection, this on the right side, the patient was having the this tumor, and on the left side this was adenoma. That means we need to know which one is the benign and which one is not is fitting into the category of aldosteronism. So that will help us to take the patient for surgery to that particular adrenal gland. So this test will guide us to take which adrenal should be removed. This is metomidate scan. This is labeled with C11, and on this images on the left side, as we can see, there is a unilateral tumor, and on the right side, we can see the bilateral tumor. So that's how it will differentiate between unilateral and bilateral tumors. The next indication for adrenal nuclear medicine indication is adrenal cortical carcinoma, where the FDG PET CT is an important investigation. It has a high sensitivity and high specificity. False positive can be seen in infection and inflammation, particularly tuberculosis and histoplasmosis, and negative can be seen in the lesion. Those are less than 5 mm. This is FDG PET CT of the patient having this adenocortical tumor, which is showing increased uptake, and there is no metastasis in the rest of the body. All other activity which we see in this scan is because of the physiological activities. Another patient having adrenal tumor with metastasis to the lung, liver, and the rest of the body, we can see from these images. So that's how it will help to classify whether that tumor is particularly localized to the adrenal gland or it has gone beyond that adrenal boundaries. This is gallium pentoxafor PET CT for this adenocortical tumor. In this, we can see the patient is having lung metastasis and the liver metastasis. And next role of nuclear medicine is in theranostics. We have different radio tracers which we can use for therapy of these adrenal tumors, including the lutetium dotatate, yttrium, then the lutetium, then the MIBG therapy. These are the different radio tracers which can be used for therapy of adrenal tumors. This is an example of one patient which underwent baseline FDG PET CT. This patient was ACC, and patient was given iodine maza therapy, and on the follow-up you can see there is a reduction of the lesion. This is physiological activity in the gut and the adrenal gland. These were the lesions. On the follow-up, this lesion has almost gone to the remission. That shows that this therapy has worked in these particular patients. So this is the summary slide of the that imaging I have discussed for this adrenal lesions, and I will come to the conclusion and take home message is that imaging is essential for adrenal functional disorders. CT and MRI are the first line of imaging. Radionuclide imaging is used for functional assessment, and combining the investigation improve the diagnostic accuracy, and we have to tailor the approach depending upon the clinical suspicion. With this, I will thank you for patience listening.
That concludes our talk about radionuclide investigations. I want to take any question from Srinagar Hall. There are many urologists are sitting in Srinagar Hall. So any one or two questions? Dr. Syed, sir.
Okay. No, we are not able to hear you. No.
And your voice is not coming.
Let's get your mic. Let's get it, sir. Get it.
Hello.
Bad point.
Yes,
Am I?
Yes, you are audible now.
My question is to Dr. Shamim. If we don't have Dotanac available here, in a bilateral pheochromocytoma with a proven VHL positive gene, so should we proceed for surgery, or we have some medical legal implications in such a case? Should we go ahead with MIBG only because the sensitivity is less in case of specificity is less in case of this sensitivity is less in MIBG? Should we proceed with MIBG only, or we should send the patient outside to Delhi for Dotana?
So, yeah, very valid question. If we don't have gallium dotanarc in particular center or in particular state, so yes, MIBG can be a good alternative to that. So you can use MIBG scanning for detecting any other lesion in the rest of the body. So that will help in detecting the multifocality of the tumor. So that's very important. But before, I think you must go for imaging to detect any other lesion, because during the surgery there can be issue if there may be any lesion in the rest of the body, and that may create problem for you during the surgery. So it is important to know the lesion, because they are known for multifocality. Initially, we used to say there is 10% extraadrenal, but now the literature is coming where we can see 20 to 30% extraadrenal paragangliomas can be there. So to avoid that complication, it is advisable to go for gallium dotanarc. If that's not available, then MIBG. And if that is not available, then you can refer to the patient to the other places.
Can I ask a question?
Dr. Shamim, there is one more point. MIBG used to be used usually in the post-op period to detect the rest of the lesions, which may get missed if MIBG is done earlier because of the sump effect and all dye being retained in the larger tumor. So these Dotanac scans, etc., are also subject to that, but that effect, or they can be used.
No, that is not case with the gallium dotanarc, because gallium dotanarc has high sensitivity and high specificity. Their imaging resolution is far better. We can go up to the 4 mm or 5 mm. So there is the particular condition or the particular situation which you are quoting, it is not common with gallium dotanarc scan. So we can go for the gallium dotanarc scan, and that problem is not there with the gallium dotanarc scan. Rahul sir, you were asking some question.
Yeah, Shamim, and it was an excellent talk and very really updating. Thank you very much. For all those who don't know, Shamim is from Jammu only. Just quick questions I want to ask. So you want to tell me that for all patients we should do MIBG? And secondly, with the PET scan, do you need a special to order specialist somatostatin to get that done, or is it you have to place a special order beforehand? How do you do it?
Sir, see, I will consider a Jammu scenario, because you are practicing in Jammu. This gallium dotanarc is not available in Jammu. So the problem is that what next option you should have? You can go for MIBG, that is even not available in Jammu. So first investigation as of now, today, gallium, initially it used to be MIBG. Now that has been taken over by gallium dotanarc. So if you are suspecting a pheochromocytoma, so the first investigation that should be done, that should be the gallium dotanarc PET CT. So if that is not available, then you can refer for the MIBG. So I think the gallium dotanarc is more widely available now as compared to the MIBG. So first you should go for the that is gallium dotanarc. That should be the first option for that.
Thank you. But in all patients, you want to suggest?
So in all patients of pheochromocytoma, the gallium dotanarc is suggested. MIBGs now have left with few indication, like if we are planning that particular tumor with MIBG therapy. So we wanted to know whether this tumor is amenable for therapy or not. If that particular tumor is showing MIBG therapy, then we can consider for the therapy. Or sometime we have a strong suspicion of pheochromocytoma. This gallium dotanarc scan may turn out to be negative only in 1 or 2% of the patients, which we have seen in our clinical practice. In that cases, we can do the MIBG. Otherwise, MIBG has been replaced with gallium dotanarc scan.
Can I ask one question?
Yeah,
Dr.
sure,
Salim from Srinagar. So about Dotanarc and the MIBG, what is the current scenario vis-a-vis the FTG PET scan in the pheochromocytoma investigations?
Sir, in pheochromocytoma, FDG PET CT has no role as of now because
Right.
Conventionally tumor having pheochromocytoma, basically they don't show FDG avidity.
Right.
If they will show, that will be very mild. So in that case, FDG is out of question in these cases. So only we are left with the gallium dotanox scan and MIBG scan. Whichever is available to you, go for that.
If we see the Campbell 12th edition, it mentions that the gold standard for the pheochromocytoma is the FDG PET scan. 12th edition of this thing. Dotanot is number 1 now. But what is the current scenario vis-a-vis FDG PET scan? I just needed to ask that.
Sir, I'm not aware of that guideline, but FDG is the radio tracer which show the metabolism. So
Right.
pheochromocytoma is the tumor which express. This is a benign tumor. So benign tumor are not supposed to take the FDG. So the tumor having FDG avidity, they will be malignant tumor. They having
Right.
more glucose utilizations, and this particular pheochromocytoma people, they show the somatostatin receptor expression. They show the dopamine intake. They express the MIBG. So these tumors don't show FDG avidity. Sometime we see that will be a false positive, if we will say
Right.
that.
Thank you.
Thank you, Shamim sir, for telling all the queries of our respected urologists. Sir, Rishi sir, can we move to our next speaker?
Yes, please go ahead.
So I invite our next speaker, Dr. Chandan. He is a radiologist from AIMS, New Delhi. He will be talking on interventional radio-oncology for adrenal tumors. Where are we, need, scope, and impact on therapy? Dr. Chandan sir, you can share your screen and slides.
Very good evening to you all. Am I audible?
Yes, sir, you are audible.
Yeah. So let me share my slide. So, can you see my slide?
Your slides are not visible.
Okay. Just a second.
This Apple product give lot of problem.
Yeah.
I also face the same problem. They don't give permission easily.
Yeah, this is the same Apple problem.
Yeah.
So
we agree.
You'll have to go to settings and give a permission for uploading.
Rishi sir, in between we can take
you can talk.
from Chairperson or Srinagar Hall. Okay. Rishi sir, you are not audible.
We can go ahead with the next talk. Dr. Yasir is also there. So
yeah, you can go ahead with the next talk till I do it. Yeah.
So now it's my pleasure to welcome Dr. Yasir sir. He will be talking on evaluation of the patient with adrenal tumors with a focus on pheochromocytoma. Dr. Yashir sir, are you ready?
Good evening.
Yes, good evening, sir. Good evening.
Is my screen visible?
Your screen is not visible, sir.
Just a second, I'm working through it. Is this my screen now?
Yes, now it's visible, sir.
Okay. Good evening to all of you, and thank you for giving me the opportunity to present on this topic. My topic for today is evaluation of patient with adrenal tumor with a keen focus on pheochromocytoma. I will start with incident lumas. As you all know, incident lumas are unsuspected adrenal masses greater than 1 centimeter in diameter, and they are identified on cross-sectional imaging performed for seemingly unrelated causes. Incidence is approximately 5%. And if an imaging study is done for signs and symptoms which are suggestive of some adrenal hormonal excess, such as pheochromocytoma or Cushing's or Cons, or if it's discovered on an adrenal mass is discovered upon screening imaging or for tumor staging or follow-up, then it will not be called as incident loma. Incident lomas, as is visible, The prevalence of different entities among the incidental are most of them are 80 to 85% of incidental are comprised of the adrenal cortical adenomas. Then other benign masses, they comprise around 10%, pheochromocytoma 1 to 5%, and renal cortical carcinoma approximately 0.4 to 4%. The imaging for adrenal tumors, the basic ultrasonography, it's basically a suboptimal imaging modality, and it is not usually done to screen adrenal lesions, but still right-sided lesions are more commonly seen because of the better window provided by IVC and liver to the adrenal gland. Three main imaging techniques are in the mainstream clinical use: CT, MRI, and PET scan. CT and MRI usually used to identify benign lesions and exclusion of adrenal malignancy, and PET CTs are usually used for detection of malignant diseases. CT has a high spatial and quantitative contrast resolution. A non-contrast CT is the most reliable imaging tool, and standard contrast NAS CT is not usually helpful unless its adenomas are to be differentiated from the malignant lesions, where contrast enhancement washout usually takes precedence. Adrenal protocol CT, again, it's done the prior to injection of contrast medium, one film is taken, and then at 60 seconds, and then at 10 to 15 minutes after contrast injection. When the threshold of 10 Hounsfield units is used, the CT scan has a sensitivity of around 71% and specificity of 98% for the diagnosis of adrenal adenoma. 30% of adrenal adenomas, more than 10 Hounsfield units on unenhanced CT. These are called as atypical adenomas, and they are usually differentiated on rapid contrast washout. This is again a CT image where there is a non-contrast image. An adenoma lesion showed a Hounsfield unit of 15 Hounsfield units, and after injection of contrast, it showed shot up to 55, and on delayed images, it came down to 27 Hounsfield units. So there are two values: absolute percentage washout and relative washout we use. And relative washout, if it's more than 40%, is diagnostic of adenoma. Recently, some studies have increased this value up to 58%. MRI, again, is a non-ionizing radiation-based imaging modality. It utilizes weak radio wave signals, which are emitted by body tissues and the body when the body is placed in a strong magnetic field. Here, the advantage of MRI over CT is that lack of radiation exposure, lack of iodine-based contrast media, and superior tissue contrast resolution. Like contrast washout seen in CT, where in MRI we have chemical shift imaging, where within magnetic field, when the proton in the water and lipid, they vibrate at a slightly different frequency, and they oscillate in and out of phase. In adenomas, they lose signal intensity on out of phase images when compared to in phase images, and the malignant lesions and pheochromocytomas, in contrast, they retain their signal. Then comes the PET scan. Here we have FDG PET, and the standard uptake value is taken to assess whether the lesion is benign or malignant. It's basically used to differentiate between benign and malignant adrenal lesions. It's superior to CT or MRI because it takes simultaneous acquisition of PET and CT data. The contrast is injected 1 hour prior to the study. FDG PET CT can help to identify metastasis in suspected adrenal cortical carcinomas, or in case of adrenal metastasis, it can also help to detect the primary tumor. Then this FDG PET is also replacing MIBG in staging non-MEN 2 patients with known pheochromocytoma. Then 68 gallium dotatate scan, it also has a superior signal to noise ratios when compared to FDG PET. FDG PET has a sensitivity of 93 to 100% and specificity of 80 to 100% in identifying malignant tumors, including adrenal cortical carcinomas and metastasis. MIBG has a limited role in evaluation of adrenal incidentalomas. It's basically MIBG is a functional and structural analog of norepinephrine, as previously mentioned by respected speakers. It has a sensitivity of 83 to 100% and specificity of 95 to 100%. It's mostly used to identify the tumors associated with VHL and SDH gene mutations. Pheochromocytomas, I'll be focusing more on pheo now. It's as I told you before, it comprises 5% of incidentalomas. Extraadrenal are termed as paragangliomas, which can arise from head, neck, thorax, abdomen, or pelvis. Then 10% rule has been challenged nowadays. Mostly 20 to 30% of the tumors are extrarenal and approximately 30% are familial in nature. Paroxysmal hypertension is a classical presenting sign. The classical triad of headache, sudden perspiration, tachycardia are is the catch here in diagnosing pheochromocytoma. Prognosis: 5-year overall survival rate in metastatic pheochromocytoma is 58%, and metastatic paraganglioma is around 80%. The molecular basis, as I told you before, hereditary syndrome, pheochromocytoma paraganglioma is hereditary in around 30 to 50%. The most common mutation seen in this group is SDH mutation, 15 to 20%. Then comes VHL, then Mantoux syndrome, where we have red proto-oncogene, and neurofibromatosis. The patients with VHL and SDH mutation mainly secrete norepinephrine, and therefore in these patients, metanephrine values are surprisingly low. The screening indication for pheochromocytoma paraganglioma are enumerated. If there is paroxysmal episode of palpitation, headache, diaphoresis, or unexplained variability in blood pressure, or there is severe treatment-resistant blood pressure, or paradoxical blood pressure response to drugs, foods, or anesthesia or surgery, orthostatic hypotension in a hypertensive patient, or new onset diabetes mellitus in a young lean hypertensive patient. These are the screening indications of pheochromocytoma. On imaging, again on CT, pheos are well circumscribed and usually more than 10 household units on unenhanced CT, average around 35. On MRI, sometimes light bulb sign seen on T2 weighted images. Functional imaging, as mentioned before in Campbell, 12th edition, FDG PET is now the gold standard in diagnosing metastasis. MRBG and SST analogs are newer age modalities, which are these are the modalities which are being considered nowadays. And functional imaging in case of sporadic pheochromocytomas, the gallium dotatate, the F-DOPA is the radiotracer of choice, followed by gallium dotatate and FDG. Functional imaging, in functional imaging, pheochromocytoma paraganglioma cells, different transporters on the surface. So different radiotracers are used depending on the capture mechanism. For example, in the cells where there are norepinephrine transporters, MIBG scan is helpful. Where there are glucose transporters, FDG PET is helpful. Where there are amino acid transporters, DOPA PET CT is helpful in those. And in case of somatostatin surface receptors, again, SST analogs can be used as an imaging modality. PET CT technology has shown to be superior to the SPECT CT in diagnosing pheochromocytomas. Gallium dotapeptide PET CT has 98 is the functional imaging of choice, where there is sensitivity and specificity of 98.6%. In polycythemia related paraganglioma and pheochromocytoma patients, 18F DOPA PET is the functional imaging of choice. When it comes to biochemical evaluation, most sensitive test is plasma-free metanephrines, as has been told before. Then comes the urinary fractionated metanephrines and vinyl mandelic acids. In case of unequivocal or doubtful reporting, we can also we can also do a clonidine suppression test or chromogranin A test. Indications for genetic screening includes family history, less than 50 years age group, in multiple tumors, in malignant tumors and bilateral tumors. This is the diagnostic algorithm for pheochromocytoma paraganglioma. If there are clinical symptoms or family history or incidental detected adrenal or extra-adrenal mass, first we do biochemical testing with plasma-free metanephrines or urinary fractionated metanephrines. And then if there is a significant elevation, we proceed for imaging studies. And if imaging studies confirm the presence of pheochromocytoma or paraganglioma, we then assess for the metastasis or the tumor size, and then we go for functional imaging depending on the receptor cells present in the tumor. But if there is slight or borderline elevation, then we either repeat the test after minimizing or removing the conditions which are responsible for the false reporting. And if there are still slight or borderline elevation of metanephrines, we can do a clonidine suppression test. This is the staging of pheochromocytoma and paragangliomas according to AGCC 8th edition. The tumors less than 5 centimeters fall in the T1 category and more than 5 centimeter T2. And if there is invasion into surrounding structures, it's T3. Treatment options again, lap adenectomy is the treatment of surgery of choice. But in case of in case of larger surgically difficult lesions, open adenectomy can be done. In hereditary pheo or bariatrial disease, partial cortical sparing adenectomy is preferred. In case of malignant pheo, the treatment is largely palliative. The options are metastaectomy or radioactive iodine MIBG treatment can be given to the patients. And it's been seen in the studies that approximately 50% of patients with metastatic pheochromocytomas are candidates for radiometabolite treatment. If the patients are still not suitable for MIBG treatment, then chemotherapy can be given in the form of cyclophosphamide, vincristine, or dacarbazine. Pre-op preparation before surgery, it's according to the guidelines, you started 7 to 14 days prior to the surgery.
Dr. Yashi, can we summarize within 1-2 minutes? Right.
Okay, so I'll try to. 7 to 14 days prior to surgery, the treatment is started, mostly with alpha-1 selective blockers and add-on calcium channel blockers, and beta blockers are given 3 days before surgery. High sodium and fluid intake, high sodium diet and fluid intake is given, and saline infusion started the evening before surgery. There are the basic guidelines, European guidelines for the again management of incidental and adrenal tumors, which has been mentioned before. According to I will just describe this flowchart and then I'll conclude. The incidentalomas, in case of if they're whether to assess if they're potentially malignant, we do a non-contrast CT. If CT the hospital unit is less than 10, the imaging is benign and we don't have to proceed any further. But if there is an indeterminate mass, then we proceed further for additional imaging or we do a multidisciplinary meeting to decide whether to proceed for surgery or do a next imaging. Then for assessment of hormone access, we have to exclude in case of again surgical treatment, I have already explained before. Yes, sir. In adrenal mass in a patient with extra-adrenal malignancy, if there are benign radiological features and if there are no relevant hormone excess, then we only manage it as a primary malignancy. But if there is hormone excess in those patients, we consider individualized treatment. In case of if there are no benign radiological features, then we exclude pheochromocytoma. And if the pathological assessment alters the clinical management, then we manage as we to take an adrenal biopsy and do an FDG PET or the resection of the external malignancy. Thank you.
Thank you, Dr. Yashi. And I would like to extend my sincere gratitude to chairpersons of the second session, Dr. S.K. Singh sir, S.S. Yadav sir, Sameer Trivedi sir, Atul Khandelwal sir, and Dr. Rock Khoja. So if there are any questions or comments or they're sharing their expertise from our chairpersons.
So one question in the last slide, you showed that for a patient with the extra-adrenal malignancy, if there is a simultaneous adrenal lesion, then functional evaluation is mandatory even in that patient. Is it true for all patients that we should do, or it is on case-to-case basis based on symptoms?
So in case of patient with extra-adrenal malignancy, if there are basically if there are symptoms present in the patient, for example, if the patient has resistant hypertension or if the patient is not responding to multiple drugs or the other symptoms which are amenable to which we can relate to fever paraganglioma, then we have to assess the hormonal evaluation and then proceed accordingly.
Okay.
Rishi sir, can we move to our next speaker?
Yeah, if there are no questions, any questions from the Srinagar side, hall? Okay, so we move on to the next presentation. Dr. Chandan, are you ready with your slides?
Yes, I'm ready. Yeah.
Yeah, so Dr. Chandan is the radiologist, professor of radiology at All India Institute of Medical Sciences, and he's going to talk about the interventional radiology. How far have we reached for the adrenal masses? Dr. Chandan.
Yeah, actually, okay. Is my slides visible? Yeah.
Yes, sir, your slides are not visible. I think it's in the process, but it's not visible right now. Yes, it's visible right now, sir.
Okay. Okay, thank you very much. A very good evening to all of you, the eminent urologists of the northern part of the India. So it's a privilege to present in front of you, and I must thank my friend Dr. Rishi for giving me this opportunity. So after this, all this fantastic lectures on different imaging, nuclear medicine, radiology, then I'll give you an overview of the how the IR interventional radiology can help in treating some adrenal tumors. Those are not feasible for surgery, or maybe may not fit for surgery basically sometimes. Okay. So basically, what are the adrenal lesions that we want to ablate? Adrenal is a very small organ, it's just in the right side. It is in the just behind, is located to the IVC. So this is the IVC, and this is the portal vein, and this is the inverted V-like structures, and this is the adjustment cross of diaphragm. So it's a very small organ that is deeply located in the abdomen, and the opposite side, this is you can see the adrenal just behind the splenic vein. This is the spleen, the margin of the spleen. So this is the celiac axis. This is giving rise to the hepatic artery and the splenic artery. The importance of image gut interventions lies on the fact that they are basically minimally invasive. Many times we do not need general anesthesia. We give most of the times we do all the things under local anesthesia. Very seldom we give general anesthesia for some ablations. It also not only helpful for guiding and interventions. Basically, it can help you in diagnosis, especially in sometimes you can want to do a FNAC or biopsy from the adrenal lesions. And it is a hospital, basically office procedure. Most of the time we do it in a short admission time. We admit the patient in the morning and discharge in the evening. So these are the radiological modalities that we use for evaluation of any adrenal masses before taking the patient for biopsy or any other ablation therapy. So MRI, CT is the most commonest investigation we perform. It is also used for guiding the interventions most of the time. MRI is usually is a problem-solving modality. So especially for those lesions which contain small amount of fat, for example, lipid-poor adenomas, we want to differentiate from other tumors like pheochromocytoma or metastasis. Then we have Dr. Shamim extensively talk about the position emission tomography. Then after localization, all these tumors that we are certainly dealing with in adrenal masses, we can offer different forms of IR techniques, starting with the biopsy. So biopsy is the commonest interventional procedure we perform from adrenal. Usually this is to obtain an histopathological diagnosis. Sometimes some conditions like pheochromocytoma that can be diagnosed nicely on imaging. We do not subject those patients for biopsy. Only those indeterminate masses, whether once, especially any adrenal lesions that is diagnosed in the context of a known malignancy, we would like to do biopsy. Then these are the commonest intervention ablation technique we use. One is called radiofrequency ablations, and another was the microwave ablation. So in our institute, we use only these two procedures. Most of the techniques actually basically we are using these two modalities for ablating liver and kidney lesions. So we have more than 200 ablations experience in radiofrequency ablation as well as the microwave ablations, but the amount of adrenal ablations is usually less. These are office procedures basically, and the basic principle is the same. We use a electric. We use a needle, and through which the electric current is passed to burn the lesions basically. Then another lesions which is upcoming is the cryoablations. Cryo basically it doesn't have pain. It doesn't require any anesthesia. So that's why even a big tumor like an adrenocortical carcinoma of like 8 centimeter, 7 centimeter can be treated with cryoablations. Most of the radiofrequency ablation technique we use to lesions up to 3 centimeter of size. Whether in microwave, we can go up to 5 centimeter. Eternal ablation is an old technique. Basically, initially it was done for any liver lesions as the liver and adrenal are closer. So people have extrapolated the eternal ablations from the liver lesions to the adrenal lesions. Usually they are done for some benign lesions like larger adrenal adenomas, which are not fit for surgery because of some non-medical causes, basically. Then coming to the indications for image-guided interventions. So most likely we do for indeterminate adrenal masses. So they need for biopsy to differentiate from benign or malignant masses, especially in the context if this patient is undergoing some treatment for malignancy. Sometimes some functional lesions like small aldosteronoma can be ablated nicely under using a microwave or a radiofrequency ablations. Then benign lesions like symptomatic benign adrenal adenomas can be also treated with ablations. So in our setup, we have mostly done all the ablations only for the metastatic lesions. They are from the kidney, lung, or breast cancers. So coming to the biopsy part, so biopsy most of the time we do the adrenal biopsy under CT guidance in a prone position. You can see this is the needle. This is the injection local anesthesia injection needle. So here we use a coaxial technique. You can see two needles basically. This one is the outer needle. This is placed just adjacent to the adrenal lesions. Then through that needle, we put another needle to take the biopsy from this lesion. So the basic advantage of the coaxial needle is that after only one insertion, you can take multiple time of biopsy. Then you can extrapolate this method to do a ablation also. For example, if putting this coaxial needle, outer needle, you take biopsy, and after you remove this biopsy needle, you can insert your the RFA needle through this same coaxial needle to ablate this tumor. So both can be done, can be combined in the single procedure. So it's a very quick procedure. It helps to differentiate benign from the malignant lesions. But sometimes what can happen, because you see the adrenal is very closer to the dome of the diaphragm. So if you transgress a part of the pleura, it can give rise to pneumothorax. So as pneumothorax is a frequent, one of the complications that we see after an adrenal biopsy. Then it can also, if you're not careful, you can injure the IVC, gives rise to retroperitoneal hemorrhage. So, or if you're not careful enough, you can go further anteriorly to hit the portal vein also. Then coming to the radiofrequency ablation. So this is, as I said, this is just an extension of the biopsy technique. So here we have gone inside to the same adrenal lesions that we have biopsied, and we use this needle and we connect it to the system, the burning system. Usually for 3 centimeter up to 3 centimeter size needle for radiofrequency ablation, you need a 5 minutes of burning time. So it's a very good technique. Only thing is that if you're like some adjacent structure, you need to insulate by you can see we have insulated this adrenal lesions by injecting some of the saline adjacent to that, so that this part is not burned. Similarly, also I would also like to inject some normal saline between the IVC, the IVC and the aorta. Sorry, this is in the opposite side. Sorry, this is in the right side. So this is in the right side. So here I would like to inject some fluid here so that the IVC is separate from the adrenal. This is the normal adrenal. So here we are doing a radiofrequency ablation on the left side. So as like the biopsy, it also has the propensity to hit the portal vein as the hepatic as well as the IVC. It can cause hemorrhage and also can cause pneumothorax. Microwave ablation is also the same. The technique is basically the same here. Only the machine is different. The probe is different. These are like tumors. This technique is good for tumors which is more than 3 centimeter in diameter, but up to 5 centimeter. More than 5 centimeter lesions are usually not suitable for any ablations. So here, this is a paper basically I've shown from this paper, Ren C et al. They have used contrast enhanced ultrasound. So they have shown like they have used this contrast enhanced ultrasound to take biopsy to ablate these lesions. So we have published a paper in 2021 from our institute, contrast enhanced ultrasound in evaluation of the adrenal lesions with CT and MRI correlations. This paper has actually extrapolated our paper and to ablate this adrenal lesions. So they have done the contrast enhanced ultrasound, and because the lesions are so enhancing nicely, you can see this is the liver, and they have created an interface between the liver and the adrenal by injecting some normal saline. Now you can see they have put a needle to burn it. So after burning, you can see the tract they have gone through the liver, and this is the post CT scan after a few days, and you can see this is the IVC, this is the kidney, and this tumor is not enhancing absolutely. And after a month therapy, after a follow-up, there you can see the masses decrease in size, and this is the enhancing kidney, and this is the IVC. So showing the microwave is a very good modality for ablation of this tumor. So this is a microwave is a faster technique compared to the radiofrequency ablations. Here, there is a heat sink effect. There is another factor called heat sink effect that happens with radiofrequency ablation. That means the amount of heat you added to the tumor, the flowing blood in the IVC, what happened? They dampen its effect. They cool down its effect. That happens with the radiofrequency ablations. So for 3 centimeter size tumor in a radiofrequency ablation, you have to ablate it for 10 minutes time. That requires general anesthesia basically. So for RFA, you have to use general anesthesia. But if you use a 3 minutes time of microwave ablation, a conscious sedation or giving in some IV analgesics is sufficient without giving general anesthesia in case of microwave ablation. Then eternal injection, as I said, it's an old technique. We do not practice this anymore because sometimes if you hit the IVC, the eternal will go into the IVC and can cause systemic effect. So this is an extrapolation of technique used from the liver tumors. So for liver tumor also, we do not use these days eternal ablations. Just mentioning. This is our from the archive. This is an adrenal lesions where we injected alcohol under ultrasound. This is the probe, and you can see the alcohol is basically disseminated inside the tumor, and in follow-up you can see the large chunk of the tumor is showing necrosis. Only part of the peripheral part is showing enhancement. Then cryoablation, this has been used extensively these days because for all lesions, small, bigger, small, medium, bigger, till 10 centimeter, people have done cryoablations. Because here, basically, they use an ice ball, and they put a transducer inside the tumor and create an ice ball to break the tumor. Here also, you need to insulate the area from the adjacent important structure like IVC. So here they have injected normal saline mixed with some contrast so that the periphery of the tumor is nicely visualized. Then they have created this ice ball, and this is usually done under CT, always done under CT guidance, and this tumor has been broken off. So mostly all the metastatic those adrenocortical carcinoma, which are more than 5 centimeter tumor these days, they have been treated by the cryoablation. There are a lot of literatures coming into it. So just to summarize, what are the advantages? It's minimally invasive technique, reduce hospital stay. It doesn't require general anesthesia, especially except for the radiofrequency ablations. Then they have a reduced risks of recovery time. Then the preservation of the adrenal function, because if you are ablating one part of the one limb, the other limb will still there. They can preserve the adrenal function, and because of the very excellent modality of imaging, so these techniques are very precise. But still, they have some limitations, like sometimes the tumor size, then complications related to the IBC injury, the lung injury, especially pneumothorax can give you a challenge. And the tumor recurrence, especially because if you're not able to ablate the completely tumor, so there is a principle that if you are not able to, if you left a little bit of tumor tissues there, then it will blown up basically. In follow up, you'll see this is true for any tumor, especially liver, kidney, and also for the adrenal. If you are not complete, the ablation is not complete, the tumor will blow up in the next follow up. I'd like to share two small cases they have done recently. You can see there's an adrenal lesions here. This is the IBC. So this is an enhancing lesions. This is basically a metastasis from RCC. Patient has undergone partial nephrectomy. So here we have done transhepatic radiofrequency ablation. So you can see the needle is inside the needle tip inside the IBC. So sorry, the adrenal. So this is the IBC. We are like, as it has got a range of burning of the 2 centimeter. So we have gone to the posterior part of the adrenal mass. If we avoiding the anterior part, because if we put this needle in the anterior part, a part of the IBC might get also damaged. So as it has got a zone of ablation 2 centimeter, so this 1 centimeter lesion, we have gone to the posterior aspect and we have ablated it completely. And in this patient, actually, you can see also there's some pneumothorax formation in the immediate post ablation, but it is a smaller one and resolves spontaneously. Another case, this is a metastasis from, I think, just from the carcinoma colon into the adrenal, or I think it's a case of adrenal metastasis from CL lung. So here you can see, as this is a larger tumor, we are using a multi-prong probe, radiofrequency probe. Again, we are trying to avoid the anterior part. So, and then you can see after ablations, this is the pre-ablation image, and this is the post-ablation. You can see the tumor is seldom visualized, and there is an area of burning in this area. So, just to conclude, radiological image-guided interfaces are valuable tools for diagnosing and treating adrenal lesions. So, as of now, the biopsy, radiofrequency ablation, microwave, and cryoablations are minimally invasive alternatives to surgery. So, whenever like some patients are not fit for surgery or for some reasons, surgical reasons or medical reasons. So these methods can be applied for treating all those benign or as well as malignant conditions. Usually the complications are minimal, but still we have to be vigilant and careful for follow-up of these patients. Thank you very much.
Okay, Dr. Chandan, you have shown that all of these techniques are feasible. But the issue with adrenals is that it is a very highly vascular organ, and giving heat to this, we would like to actually know the efficacy. How efficacious are these in completely ablating the lesion? These are mostly benign diseases, and if we are able to ablate the functional part of it, then these should be more popular. Don't you think so?
Yeah, absolutely. This functional for like functional tumors, it's gaining popularity. As you said, adrenal is a vascular, yes, but all these techniques except for the cryo, the radiofrequency ablations are and the microwave ablation. These are all basically electric. They just ablate, and you can also ablate the tract also. So so that there is no like bleeding from the tract, you can burn the tract also. So you just like you cauterize, the same principle, cauterize during surgery or a laparoscopic surgery. These are the same technique you use for that. So obviously, this is gaining popularity, especially the cryoablation is also gaining popularity because it doesn't require any sort of anesthesia. And it can be used for larger masses like adrenocortical carcinoma 10 centimeter, where there is even lung metastasis. Basically, in the some sort of basically it's a palliation also is possible with the cryo.
But basically, you restrict it to those persons who are not medically fit, probably, or it is a treatment of choice. And
The treatment of choice, basically, it depends on the referral, basically. Many a times, just like there are, for example, if you take compare to the adrenal, you take kidney, there are small SRM lesions. There have been ample papers coming that the partial nephrectomy and the ablations, cryo or microwave, are as good as partial nephrectomy. But still, there is a referral bias. We are dependent on the surgeons or the urologists, basically. So if the surgeons are like willing to do a surgery, will not get for ablations if they are. Most of the times we get the patients when they are not fit for surgery or anesthesia, basically. But these are very small technique, hardly takes 10 minutes.
Any experience from Srinagar or Jammu scheme site?
I need to ask a related question vis-a-vis the biopsy, needle biopsy in situations as sir was saying. Do we recommend the biopsy because of the fear of seedlings from the needle track? And obviously, these procedures, ablations, other things would be recommended for the unresectable tumors or the metastatic tumors. I just need to ask from Professor Chandan, what about the chances of needle seedlings happening if we do the biopsies?
So we are using a coaxial technique. So we push the outer needle as close to the adrenal. Then through the needle, we take the biopsy needle. So whatever happening, the tumor cells settle inside the outer needle, basically.
Right.
So the biopsy gun is not exposed to the outer normal tissues, basically.
Right. It is the normal biopsy gun which we use, the tetracut biopsies? Is it the same needle?
It's a semi-automatic system where there's an outer outer needle, there's an outer needle and there's an inner needle, basically. It's a semi-automatic biopsy system.
Dr. Tandon, I have a question. Before you go for any biopsy, do you evaluate for any functionality of such tumors? Is it a routine, or you can go ahead on the basis of CT imaging or your imaging technology only, or you do functional study in all cases where you go for biopsy?
Sorry, sir, can you repeat the questions once again?
I want to know, am I audible?
Yeah, you are audible, sir.
Are you doing functional evaluation for all such regions where you go for biopsy, or you just rely on your imaging only before you go for any biopsy?
We rely on imaging. If we are sure that this is not a pheochromocytoma, then we go for biopsy.
So in another way, is there any risk of hypertensive crisis?
Yes, that's why we want to exclude pheochromocytoma first.
Right. So any question from respected chairperson? Samir Trivedi sir is there, I think. SK Singh sir or SS Yadav sir. Any questions or their comments or expertise?
Any radiologist who are doing an adrenal biopsy or a renal biopsy, basically they are capable of doing this adrenal ablations. This is hardly a 10 minutes procedure. If you are using microwave, it hardly takes 3 minutes for an ablation of an adrenal.
Thank you, Chandan sir, for very insightful and informative talk. I think now we should move to our next speaker.
Thank you.
Dr. Naik sir. He will be talking on adrenocortical carcinoma recent evidence.
Thank you, Lalit. Lalit, can you see my slides?
Yes, sir. Your slides are visible and you are clearly audible also. You can go.
Thank you, Dr. Rishi, for the invitation. And I must thank Dr. Kevin. He's a fellow with us for his help in preparing this presentation. So, Kevin, thank you if you are there in the audience. So, the talk today that has been given to me is the recent advances in the management of adrenocortical carcinoma. So, this is actually the recent advance. So, I must tell what was there before and what is the change now. So, I'll be speaking on pathogenesis, diagnosis, staging, surgery and its approach, adjuvant treatment, radiation and systemic treatment. These are the headings I will for in my presentations. So, adrenocortical carcinoma is a very rare malignancy. Unlike your other adrenal lesions like pheo or aldosteronoma, adrenocortical carcinoma is very rare in an year. In our center, we must actually we might be seeing around less than 10, maybe 4 or 5 cases per year. But on the other hand, for pheochromocytoma and aldosteronism, we see it very, very frequently. And Dr. Raji must have done more than 400 cases of pheochromocytoma. So talking about adrenocortical carcinoma, it has a very poor prognosis. Despite curative surgery, there is a high chance of local recurrence or metastasis. And because of the rarity of the disease, there is very scarcity of the trials. And it has a bimodal incidence, one in the childhood and another in the 4th to 5th decade. And there are some recently discovered risk factors like male smokers, increased estrogen use in females like OCP. So now coming to the pathogenesis, initially it was thought actually, the initial insights was it is actually part of the familial disease like Lee-Framan syndrome, Beckwith-Wiedemann syndrome and Lynch syndrome, etc. But now there is a thinking most of the adrenocortical carcinoma are actually sporadic. The genes that are involved as P53 and RB1 and etc. So initially you were thinking it's actually part of the familial disease. Now actually mostly it's a sporadic with some genetic alteration. Coming to the diagnostic part, 60 to 70% of, as Dr. Yashdeep Gupta initially said, 60 to 70% of these malignancies actually show hormonal excesses, starting with cortisol, androgen, and aldosterone. The CT features usually they have hemorrhage, necrosis, and sometimes there is vascular invasion. And basing upon the size, if the size is less than 4 centimeter, the chances of adenocortical carcinoma is only 2%. If it is more than 6 centimeter, there is a very significant chance it can turn out to be ACC. The chances is more than 25% chance if the size is more than 6 centimeter. At the same time, if the hospital unit is more than 20 units, it suggests actually more in favor of ACC. FDG PET has a very limited role. Very recently, there is another PET CT, recent functional imaging, that is metomidate labeled C11 PET CT. It has a very high sensitivity and specificity for ACC. So there are certain parameters that normally being used, though we routinely do not use to diagnose ACC, all these urinary steroid metabolomics, as Dr. Yashdeep Gupta also said, even in tertiary care center, these are not very commonly used, urinary steroid metabolomics, but this can be actually used using your gas or liquid chromatography or mass spectrophotometry from the urinary analysis, where you actually see the excessive secretion of the steroid hormone precursors. Instead of the normal product of the steroid synthesis, you actually see more secretion of the steroid hormone precursors in these ACC. So this is actually another paper which shows the urine steroid metabolomic as a biomarker tool in detecting malignancy. On the left side, you see the adenocortical adenoma. These biomarkers, the precursors are not significantly raised, wherein in ACC, these are significantly raised, these urine steroid metabolomics. This is an important paper from Lancet, which actually show there is a triple test strategy to detect your ACC detection rate to the tune of almost 76%. Though we routinely do not use all these three triple test strategy, what it says, if the tumor size is more than 4 centimeter, and if your HU is more than 20 Hunts per unit, and also at the same time, if your urine steroid metabolomic falls into the high risk category, if all three parameters are there, then there is a very high chance of detecting almost 76%. This can turn out to be an ACC. So coming to the pathology, routinely the pathologists use actually the OS system. This from 1984. This is most widely used, the OS system, that actually basically uses the nuclear grading, mitosis, and the presence of vascular, capsular, or sinusoidal invasion. Depending upon this presence or absence of these factors, the scoring is given either 0 or 1. If your OS scoring system between 0 to 2, it actually indicates an adenocortical adenoma. If the score is more than equal to 3, that goes in favor of adenocortical carcinoma. This used to be very routinely used even till today. The pathologists routinely use this OS system. However, recently there have been other introduction like use of MIB1 labeling index, the use of reticulin testing, Ki67 testing, Ki67 staining. All these parameters are being very routinely used for adenocortical carcinoma pathology reporting, because the Ki67 index actually has some role to decide whether the patient should receive adjuvant therapy after the surgery. Coming to the staging system, the initial staging was AJCC that was used in 2004. Recently, there has been a modification to that 2004 AJCC staging. The European Network for the Study of the Adrenal Tumor, actually there is a modification, and this has been incorporated into AJCC 2017. The only difference between the AJCC 2004 and AJCC recent ENST 2000 is actually 2004, the lymph node positive and metastatic disease all were clubbed together into stage 4. However, recently the lymph node positive has been separated into stage 3 and metastatic disease is put into the stage 4. So if you look at the staging, if it is confined to the gland and the size is less than 5 centimeter, that is stage 1. If it is confined to the gland again and the size is more than 5 centimeter, it becomes stage 2. If it is locally advanced because of the vascular invasion or some adjacent organ invasion, that becomes stage 3. If it is distant, or there is lymph node positivity, that becomes stage 3. If it is distant metastasis, that becomes stage 4. So coming to the surgical part, for adenocortical carcinoma, complete R0 resection is the only chance of the cure. En bloc removal of the tumor along with adjacent structure, any adjacent structure including the kidney and maybe pancreas and spleen, whatever the adjacent structure are involved. If you can give an R0 resection, that's the best treatment option that's available for the patient. If there is an intraoperative tumor rupture and spillage, these patients are likely to have very high recurrence and extremely poor survival. So hence, there are papers actually recommending this sort of surgery, particularly the ACC should be done in high volume centers, those who are having experience in handling these adrenal tumors. Coming to the choice of the surgical approach, whether one should actually do open surgery or laparoscopic surgery, there is actually a controversy. In the beginning, in 2010, there is a paper that says laparoscopic resection is inappropriate in patients where you actually suspecting adenocortical carcinoma, or if it is a known adenocortical carcinoma, laparoscopic resection is inappropriate because of the difficulty in achieving the R0 resection and the infiltrative tumors with indistinct planes. Sometimes you do not get adequate exposure and there is chance of capsular rupture during laparoscopy handling. And this can also lead to port side recurrences. However, there are recent studies that actually shows laparoscopic surgery can safely be performed in localized adenocortical carcinoma. These are two other papers that I have shown here. The laparoscopic versus open adrenalectomy that shows the in localized ACC with a diameter of less than 10 centimeter. An experienced surgeon is not laparoscopic adrenalectomy by an experienced surgeon is not inferior to the open adrenalectomy with regard to the oncological outcome. So what say that says if you have a good experience, laparoscopic and open approach do not have a different oncological outcome, particularly in localized adenocortical carcinoma. This is an important systematic review that was published in IJU. It was written by one of our fellow again. As per this review, for localized stage 1, if the size is less than 5 centimeter, it can be operated using laparoscopic approach. If it is stage 2, it can again be done with minimally invasive approach if there is no evidence of invasion and if the surgery can be performed without capsular perforation, without conversion to open. So again, the experience of the surgeon comes into play. So what they actually are trying to tell, for less than 5 centimeters tumor, it's okay. For more than 5 centimeter, again, it's a debate. So again, previously, the American Association of Endocrine Surgeons and American Association of Clinical Endocrinologists, the recommendation was to do only open resection for all cases of the ACC, regardless of the size. But now, the European Networking System for Adrenal Tumor and European Society of Endocrinology they say laparoscopic resection is a reasonable option for localized tumor if the size is less than 6 centimeter in diameter. As per the lymphadenectomy, again there is controversy. The 5-year overall survival rate is 76% if you do a lymph node dissection in comparison to 59% if you are not doing lymph node dissection. But again, there are papers that shows there is no survival advantage if you are actually not doing lymph node dissection in adenocortical carcinoma. But the recent paper actually shows there is an oncological benefit of lymph node dissection in patients undergoing curative resection for the localized adenocortical carcinoma. Coming to the adjuvant therapy, the long-term outcome for adjuvant therapy, the adjuvant treatment that is available for ACC is actually mitoten. This is the only adjuvant treatment that's been commonly used for adenocortical carcinoma. There are two schools of thoughts. Actually, some papers that has actually shown the long-term outcomes of adjuvant mitoten in patients with a surgically resected ACC. There is benefit if you give them mitoten. They have prolonged recurrence-free survival. At the same time, there are also papers that from 13 institutions from United States that shows there is no survival recurrence-free survival advantage if you give mitoten after adenocortical carcinoma resection. So there are two different school of thoughts again. However, the guideline do recommend patients, those who have a high risk of recurrence, particularly if it is a stage 3 locally advanced, and if there is an R1 resection, there is margin positive, and if the Ki-67 index is more than 10%. So one need to look at all these three factors. So that's where the Ki-67 is important in pathological when the pathologist gives the report, if your Ki-67 is more than 10%, if there is a margin positivity, and if it is a vascular invasion when it is stage 3 or lymph node positivity. If these are the factors are there, the guidelines do recommend to give adjuvant mitoten.
Can you quickly conclude?
I'm just finishing, just 2 more slides. And however, if it is stage 1 or stage 2, R0 resection, Ki-67 less than 10%, there is no benefit of giving adjuvant mitoten. Regarding radiotherapy, till 2013, only 6% patients who are actually receiving adjuvant radiotherapy because this thought to be a radio-resistant tumor. However, now adjuvant radiotherapy actually has shown improved recurrent-free survival and overall survival. So these are the factors that one need to look into because before deciding whether to give adjuvant mitoten and radiotherapy, margin positivity, Ki-67 and other parameters. Finally, the systemic therapy, due to the very less effective therapy, mitoten was, however, the only FDA-approved drug that was used for systemic therapy. But after the Farm Act trial, the mitoten along with etoposide, doxorubicin, and cisplatin have been used for systemic therapy for metastatic disease. As for the immune checkpoint inhibitor, this group immune checkpoint inhibitors so far has not exhibited any better response rate, particularly in patients with ACC. So I'd like to just conclude because I'm running short of time. Thank you very much for the patient hearing, and thank you, Dr. Rishi, again for the opportunity.
Thank you, Nayak sir, for beautiful presentation. And we can take one question from any chairpersons or attendees of the webinar. Or any question from Srinagar Hall.
Okay, Singh is there, sir.
Yes,
Sir, please unmute, sir.
Sir, your voice is not coming. Sir, please unmute.
Yeah.
Yeah. Yes, sir.
Yeah. Now you can hear me. Yeah. Yes. Good evening to all of you. I think adenocortical carcinoma is not rare in our institute, at least in our experience. Hello.
Hello.
Yes, sir.
Hello.
Yes, sir. We can hear, sir.
Yeah, adenocortical carcinoma is not so rare. Even private, sir, I have operated 2 cases in last 2 years. So it is described as rare, but India it is not rare.
So maybe, sir, actually we're in the tertiary care center that actually most of these cases actually get referred here.
Yeah,
if
right.
actually
Maybe.
to the other
Right.
tumors like your FEO and aldosteronism, it is extremely rare. Yes, I agree because we are in a center where actually we get the cases. Maybe actually in our center we must be seeing around less than maximum maybe 5 to 6 cases per year. But that's
Yes. Yeah, so that doesn't make it rare. So actually in our institute, because we are having a referral case.
Yes, but
so maybe that's right. Thank you. Yeah. I think due to sort of time, I will not interview much.
Right.
And I have been listening to all of you who have put a lot of effort. Actually, there has been one seminar and symposium, I will say, in USI. I remember Dr. Rajiv, Professor Rajiv and Dr. Mallikarjuna. They have actually, this is so uncommon to discuss adrenal tumor among urologists that yes, the audience, this symposium was so powerful that an AUA representative, they were sitting, they arranged within 3 months during AUA, they invited all those people, Dr. Sir Rajiv Kumar, Dr. Mallikarjun, whoever had been participating in the symposium, that they have plenary session during AUA 2013. So I very much remember. So it's very nice that all of you have made it this topic again being discussed for 3 hours. Only thing I will say that yes, please just stick to time. Thank you.
Thank you. But just since Dr. Rahul has put it, whether one should use mitoten or not, I think the guidelines is very clear. If there is a high chance of recurrence, particularly stage 3, or if the Ki-67 index is more than 10 and margin positive after surgery, those are the cases actually the guidelines do recommend to give mitoten adjuvant.
Right, sir, right. So now we move to our next speaker. Dr. Chetan Sharma from Jammu. He will be talking on bilateral adrenalectomy, impact on longevity, quality of life, and management.
Thank you, Lalit sir. I'm going to share.
Yes, Dr. Chetan, you can share your screen.
Is my screen visible?
No, it's not visible yet. In between, I want to welcome chairpersons of our third session, Dr. Rajiv Kumar sir, Dr. Himanshu Pandey sir, Dr. A. Sandhu, Dr. Pempos Raina, and Dr. Ishwar Ramdayal sir.
So is it visible now?
Yes, it's visible now. You can go. You can start your talk. Please start.
Thank you, Lalit sir. Thank you, Northern USI, for the opportunity. I am here to talk about on a topic of bilateral adrenalectomy, impact on longevity, quality of life, and management. So adrenalectomy is not a frequent operation which is performed in all urological centers. High volume surgeons is being defined as surgeons who are operating more than 4 cases per year, and high volume centers are centers where more than 14 cases per year are being operated. Synchronous bilateral adrenalectomy is one of the rarest operations that is being performed worldwide, and it is because of certain limitations that the indications are few in number, and because of this, the literature is also limited. Refractory Cushing disease, which is refractory to transsphenoidal resection of pituitary gland, or which is refractory to medical treatment, or which is refractory to radiation therapy, is the most common indication for bilateral adrenalectomy. Another indication include ectopic ACTH syndrome, which can be caused by a tumor, most commonly lung tumor, which is usually unresectable and or unidentifiable. Another indications include primary bilateral adrenal hyperplasia, severe or refractory congenital adrenal hyperplasia, bilateral adrenal tumors, which can be benign, include pheochromocytoma, or malignant, which can be primary or metastatic. Before 2000 era, the bilateral adrenalectomy was performed as two-stage procedure, one after the other. But with the advancement of medical and surgical management, simultaneous bilateral adrenalectomy is performed nowadays. And over the past 2 decades, the technique has been evolved from open to laparoscopic and to retroscopic adrenalectomy. Laparoscopic bilateral adrenalectomy is currently the standard of care, and it is feasible and safe because of known advantages for any laparoscopic surgery, like less post-operative pain, shorter hospitalization, less wound complication, and faster recovery. Management after bilateral adrenalectomy is also important because the patient is on long-term adrenal replacement therapy. And as we all know, adrenal is divided into cortex and medulla. Cortex is divided into 3 zones: glomerulosa, fasciculata, and reticularis, which secretes mineralocorticoids, glucocorticoids, and adrenal androgens respectively. Adrenaline and noradrenaline is secreted by adrenal medulla. Now, which to replace and which not to replace? Cortisol is one of the important hormones that regulates the functioning of each and every cell of our body at the basic level, and life without cortisol is impossible. Therefore, it is necessary to replace cortisol or equivalent synthetic glucocorticoids such as hydrocortisone, cortisone acetate, prednisolone, or dexamethasone. Normal daily production of cortisol by human body is 15 to 25 milligram per day, and it is maximum in the morning, and it is intermediate in the daytime, and it is very little during the night. Therefore, replacement should be done in the same order, as equivalent of hydrocortisone in 3 divided doses. For example, 10 milligram at 7 a.m., 7.5 milligram at 11 a.m., and 5 milligram at 3 p.m. In case of acute stress like infection, accident, or surgery, there is increased cortisol secretion from the body, approximately 2 to 3 folds to overcome that stress. Therefore, it is mandatory that patients with bilateral adrenalectomy should learn how to increase how to increase the glucocorticoid 2 to 3 fold increase. And if if this demand is not met, it can lead to adrenal crisis, which can be fatal. Aldosterone is essential for maintaining blood pressure, blood volume, and sodium and potassium concentration. Therefore, replacement is also necessary. Replacement is done by synthetic drug named fluorocortisone, which is given 50 to 300 micrograms per day, morning dose. And there is no need to increase dose in case of acute stress, unlike cortisol. There is no need to replace cortisol in males. However, in females, if they are showing signs of adrenal androgen deficiency like muscle wasting, loss of libido, chronic fatigue, this androgen therapy can be considered, but it is not necessary as it is not life threatening. Now, how to decide whether catecholamine should be given or not? If after bilateral adrenectomy, patient is retaining normal fight and flight response, that means his body is producing noradrenaline from extra adrenal sympathetic and parasympathetic nervous system. Therefore, it need not to be replaced. And most of the patients after bilateral adrenectomy, they retain normal fight and flight response. Therefore, it is not mandatory to replace catecholamines after bilateral adrenectomy. How to assure that the patient is taking adequate replacement after bilateral adrenectomy? There are few criteria. The most important being the sense of well-being is the best indicator whether the patient is taking adequate replacement. Other criteria include avoidance of symptoms of adrenal insufficiency, which include weakness, anorexia, nausea, vomiting, fever, hypotension, and tachycardia, absence of orthostatic hypotension, and normal serum electrolyte concentrations. Most of the patients show significant improvement in their quality of life after bilateral adrenectomy, especially the patients with refractory Cushing disease. And lifelong hormone replacement therapy is necessary, but some patients, they still face challenges with fatigue and mood swings, and also faces a challenge in managing medication schedules. In most of the studies, quality of life is improved significantly, but it is not that much, and it is reduced when compared to a matched population. Quality of life can be affected because of the long-term complications of long-term adrenal replacement therapy, which includes adrenal crisis. It can happen when there is acute stress like infections, like surgery or trauma, when demand is more and it is not met, and can lead to adrenal crisis, which can be fatal. Or there can be steroid over replacement, which can lead to Cushingite features again. Or there is one more term called Nelson syndrome. It is basically a rare side effect and serious side effect of after bilateral adrenectomy, and it is characterized by invasive macroadenoma of pituitary gland. And because of how it happens, it is because of the decreased glucocorticoid feedback from the adrenals. If we talk about longevity of patients with bilateral adrenectomy, if we study the natural history of Cushing disease, 5-year mortality rate is greater than 50%. But following bilateral adrenectomy, these patients, they live a near normal life expectancy if they diligently follow their hormone replacement therapy regimen. However, longevity also depends upon the underlying condition for which surgery was done, and pre-operative patients' overall health, and post-operative potential complications like Nelson syndrome, adrenal crisis, and steroid over replacement. In conclusion, bilateral adrenectomy can be a life-changing procedure for patients with Cushing disease, offering significant relief from debilitating symptoms of hypercorticolism. Laparoscopic adrenectomy has become the standard approach, with advantages of shorter hospital stay, less trauma, and low morbidity. Due to progress in surgical and general medical treatment outcomes in the last has improved in the last decades. However, the need for lifelong hormone replacement therapy and the long-term complications mean that patients may still face challenges affecting quality of life. Careful management, regular follow-up, and patient education are important to optimize outcomes and help patients adapt to life after surgery. In order to maintain normal life expectancy and good quality of life, it is very important that patient must learn to follow very closely the recommended daily timing doses of hormone replacement and to make proper adjustment in case of emergency. Thank you.
Thank you, Dr. Chetan, for finishing on time. Any question from chairpersons or audience?
I'll just make a
Only
couple
one
of
question,
comments.
right?
Lalit, this is Rajiv. I'll just
Rajiv,
make a couple of comments. Good presentation. One is that the commonest indication that we today have of bilateral adrenalectomy is actually pheochromocytoma. We have, I mean, the article should appear in the Indian Journal of Urology when you said that there is no data. It should actually appear in the next issue. I've just proved it. 51 cases of bilateral adrenalectomies, 48 of them were laparoscopic simultaneous, and the majority of them were effuse. Our experience now has expanded to 61 bilateral adrenalectomies, which we've now submitted for publication as a part of a different manuscript. And again, the commonest indication is FEO. The other important thing I wanted to say was that we actually don't need to replace anything other than prednisolone and fluorocortisone. We've never needed to replace catecholamines or anything, and the replacement dose typically is about 15 to 17.5 milligrams of prednisolone per day, 2 divided doses, and 50 to 100 micrograms of fluorocortisone. Again, that's about all that we need to do. Otherwise, I mean, that's the only other two thing I wanted to say. But a great talk. Thank you.
Right. So these are very insightful comments. Rajiv sir has experience of a lot of adrenalectomy. Used to see every 3 to 4 cases every week. And he has published recently a systematic review in Indian Journal of Urology. Right. So we will move to our next session. So first talk in next session is of Dr. Riaz. He will be talking on functional adenomas. I request further speakers to cut down your talk. If it will be better if it can be completed within 10 minutes, as we are running short of time. Right. Dr. Riaz.
So we are trying to connect it. I'm sharing my slides just now.
Dr. Riaz, your voice is not clear. It's not audible clearly.
Just speak a little loudly and into the
Hello,
mic. Yes.
sir. Am I
Yes.
audible now?
Yes, yes, it's fine now. Yes.
Good
you
evening,
can
sir.
go. Right.
Desktop पर तो बनना चाहिए। मैं किसी ऑप्शन में सर्विस ऑप्शन मिशन वन के टेस्ट की उसमें थी नहीं गॉड कॉल पर गॉड पोल से पता स्क्रीन शेयर चेंज पता ठीक है बन के इतने क्या है पेन ड्राइव पर सच ही इतना इसमें कौन सी प्रेजेंटेशन यस ये चाहिए जी ये है शेयर आप कौन से Sir, are my slides visible to you?
Your slides are not visible. You have to...
Share. Actually, but I share.
अर्जी मैंने मैक्सिमम
Or share. Okay, combining share. So can you see the? What?
Yes,
Okay.
now slides are visible.
Okay,
you
sir.
can go ahead.
So, good evening, Chairpersons and respected teachers. I'm Dr. Sheikh Riaz Ahmed from the Department of Urology, Government Medical College, Srinagar. I'm a post-MCS student. I'll be presenting a talk on functional adenomas today. Sir, as we see the definition of an adenoma, it's a benign tumor of epithelial tissue with glandular origin or glandular characteristic or both. In adrenal adenomas, we have two types of adenoma. One is the non-functional. They are the most common type. And the second is the functional type. वहीं जाओ ना कंप्यूटर के हो रहा है ना Sir, as far as the distribution of adrenal tumors is concerned, more than 50% of adrenal incidentally detected tumors are non-functional. As far as the latest consensus is concerned, and rest of the tumors, we have a new entity, what's known as MACE adenomas, that is mildly autonomous cortisol secreting tumors. And the second one is
Yes, the slide is stuck on the first slide.
Stuck on first page.
Not moving.
Next one. Share. Share. Slide shows share corner. Slide show कर move seconds. I think it's told he is stuck. लैपटॉप पे जा कराना है उसको क्योंकि ये किसी ठीक है एक दो दिन में इसने चलाने हैं तो ये होना tan patrzmy na sumie albo ja jego albo ja to się dosunę share control service maximize share this one slide share
This is a
Yes, it is. Yes, it is working now.
yes. Now
Just
it's
make it full screen.
display
It doesn't matter. Just if you can move this just like that, you can. Yeah.
Sir, as far as the latest distribution of these adrenal tumors is concerned, we have a major chunk of more than 50%, which is comprised by non-functional adenomas. And in the rest of the tumors, we have a new entity, what's known as MACE, that is mildly autonomous cortisol secreting tumors. They comprise almost 30 to 40% of the functional tumors. And then we have a small entity, what's known as overt Cushing's secreting adenomas, or the third is the aldosteronism. That is a primary aldosterone secreting tumors or the adenomas. As far as the previous distribution was concerned, initially what is mentioned in the 12th edition of the Campbell also, they used to say that only 11.2% of adrenal incidentalomas are functional, but this consensus, this thing has been challenged, and the latest guidelines as well as the latest literature says that almost about 40 to 42% of adrenal incidentalomas are functional, with a major chunk comprised of MACE. So as far as the functional adenomas, that means the benign adrenal tumors are concerned, we have three entities as present if we club together. One is the MACE, that is mild autonomous cortisol secreting adenomas. Second is the overt Cushing's adenomas. Third is the aldosterone secreting adenomas. And as far as any adrenal lesion is concerned, evaluation starts with CT or the adrenal protocol CT. Initially, we do a plain CT imaging, and on that we see the Hounsfield unit of a lesion. If it is 10 or less than 10, this points towards an adrenal adenoma, or if the Hounsfield unit is more than 10, we go for the washout study, in which if we have the absolute washout of greater than 60% or a relative washout of greater than 40%, it points towards an adrenal adenoma. The second step in the evaluation of any adrenal mass, or for that reason a benign adenoma, is the functional evaluation, which starts with the evaluation for the symptoms and signs of adrenal hormone excess, and then the biochemical evaluation, which starts with cortisol evaluation and aldosterone evaluation. I'll be dealing individually in the coming slides. So as far as the biochemical evaluation starts, the first is the OND, overnight dexamethasone suppression test, which starts with a 1 milligram of dexamethasone at the night, and we evaluate for the cortisol level in the morning. And additional tests like late night serum cortisol measurement or 24-hour urinary fractionated cortisol levels also. And as far as the aldosterone hypersecretion is concerned, we do the screening test of choice is the ratio of morning plasma aldosterone and renin, ARR of 20, along with the concomitant aldosterone concentration of about 15. Confirmatory tests, we have a lot of 4 to 5 confirmatory tests. I'll be dealing them separately. And as far as the localization is concerned, we can do adrenal vein sampling. So starting with the first entity, that is the MACE, that is mildly autonomous cortisol secreting adenomas. This is a new entity which has been described by European Association of Endocrinologists in details, and in which we can find there are classical clinical symptoms are absent. Urinary free cortisol may be normal or near normal. ACTH and DHEAS usually low. Only abnormality may be failure of full cortisol suppression after low dose dexamethasone. Gold standard tools to diagnose MACE is we can have abnormal findings on non-cholesterol scintigraphy, or there can be post-surgical adrenal insufficiency or improvement in the comorbidity after surgery for adrenal tumors, or those patients who have these lesions can have increased mortality. There's a study by Lopez et al. Which has been done in 2016. They have clearly shown that these tumors, that is the mace secreting tumors, these patients have increased comorbidity, especially as far as the diabetes and metabolic syndrome is concerned, as compared to the non-functional adrenal tumor patients. So evaluation of these mace tumors is the only abnormality what we can detect in these patients is abnormality in 1 mg dexamethasone suppression test, possibly a functional value of about 1.9 to 5 micrograms per DL is found in these patients. So as far as the imaging of these patients is concerned, what has been written in a classical recent paper, we'll have an adrenal tumor on one side, and on the contralateral side, the adrenal limbs appears to be thinned out. And they are trying to trace out a correlation between the thickness of the contralateral adrenal limbs in case of mace tumors. And a rough estimate is if the adrenal limb thickness is less than 1.8 mm, these radiologically points towards mace. So management of these mace tumors is concerned, if it's a unilateral tumor, we go for unilateral adrenectomy, and if it is a bilateral, we can go for bilateral simultaneous, or we can go for bilateral cortisol sparing adrenectomy. The second entity is Cushing syndrome. That means those patients who overtly secrete the cortisol. The incidence of these tumors is about 2 to 5 per million per year. And as we all know that zona fasciculata secretes 20 mg of cortisol per day. It's being controlled by HPA excess. So as far as the Cushing syndrome is concerned, as far as the general evaluation of these patients is concerned, we have to rule out the exogenous iatrogenic steroids. After we have ruled out that there's no source of exogenous steroids, we just evaluate the patient for endogenous source of excess cortisol, in which we have two groups. One group is ACTH dependent and the second is ACTH independent. And mostly we are concerned with ACTH independent in this group. That means the adrenal tumors, they comprise 10% of these tumors. So these patients mostly present with central obesity, round face, facial plethora, decreased libido, purple stria on the abdomen, and there can be menstrual irregularity and other features like the erectile dysfunction, hypertension, muscle weakness, posterior neck fat deposition, body bruising, glucose intolerance, diabetes, osteopenia, osteoporosis, emotional liability, depression, headache, backache, limb edema, recurrent infections, hypokalemic alkalosis, nephrolithiasis, acne, and alopecia. So as far as the evaluation of these overt Cushing syndrome is concerned, it starts with confirmation of the hypercortisolism as a first step. The second step is we have to evaluate whether it is ACTH dependent or ACTH independent. And the third step is if it is ACTH dependent, we have to find either it's a pituitary or an ectopic source. So as far as the confirmation of hypercortisolism is concerned, we have tests like low dose DEXA suppression test, which is the most widely used test and has the highest sensitivity. 1 mg of dexamethasone is given to the patient in the evening and we measure the serum cortisol next morning. Dexamethasone fails to suppress the cortisol level in case of Cushing syndrome. The other tests like the 24-hour urinary free cortisol levels can be also used, or the late night salivary cortisol measurement. Second step is we have to evaluate whether it is ACTH dependent or ACTH independent, and as I have already enumerated, the third step is we have to find in case of ACTH dependent whether the source is pituitary or the exogenous source. Once we have evaluated these patients, overt Cushing syndrome patients, the management is if it is a unilateral adrenal tumor, we go for adrenectomy. In case of bilateral, we go for bilateral adrenectomy or subtotal adrenectomy. Those patients who are unfit, or if we are bridging them towards the surgery, we can start with medical treatment like metyrapone, aminoglutamide, ketoconazole, etomidate. As far as the post-op management of these patients is concerned, supplemental cortisol should be given after the surgery, which is being mostly managed in high dependency unit in coordination with the endocrinology colleagues. The third entity is the Conn syndrome. That means the excess secretion of aldosterone. As we all know, it is a part of renin-angiotensin-aldosterone system. Patients with decreased sodium, patients with sympathetic stimulation, or patients with low renal perfusion, there is activation of JG cells with the secretion of renin. Ultimately, it culminates into the excess production of AG2, which results in excess production of aldosterone in the normal circumstances and fluid retention. But in case of primary aldosteronism, aldosterone secretion is independent of RAS renin levels. As far as the causes of primary hyperaldosteronism is concerned, as in our case, we are primarily dealing with adenomas. It comprises of 35% of the total causes. So where to evaluate these patients? Who are the patients where we should evaluate for the excess aldosterone secretion are the hypertensive with hypokalemic patients, resistant hypertensive patients, those who are on 3 or more oral anti-agents on including a diuretics, or those controlled hypertensive patients who have 4 or more antihypertensive drugs on, or patients with adrenal incidentaloма with hypertension or hypertension with sleep apnea. In addition to hypertension, these patients, about 30 to 35% of patients usually present with mild hypokalemia with features like mild polyuria, polydipsia, muscle weakness. And as far as the screening of these patients is concerned, screening test of choice is the ratio of morning aldosterone to the renin ratio, that is ARR of 20, along with concomitant aldosterone concentration of about 15 nanograms per ml. Confirmatory test in the form of fluorocortisone suppression test, which was previously being used. Now oral sodium loading test, IV saline infusion test, or in case of high risk patients who are having cardiac or renal disease, we go for captopril suppression tests. And as far as the imaging evaluation is concerned, on imaging we may find an adrenal adenoma of a size greater than 1 centimeter with a Hounsfield unit less than or equal to 10 Hounsfields. And as far as the management is concerned, in case of unilateral tumors, we mostly stuck to the unilateral adenectomy. And in case of bilateral, we go for bilateral adenectomy, but the dictum is usually to go for unilateral first and to complete the next side later. And as far as the medical management is concerned, aldosterone RT antagonists like the spironolactone or epinephrine can be used. Thank you.
Thank you, Dr. Riaj, for comprehensive talk.
Okay.
I think we will take the question after next presentation.
Okay, sir.
Next presentation is also from Srinagar. Dr. Tanveer Iqbal will be talking on bilateral pheochromocytoma. In between, if there are any questions.
Share.
Rajiv sir, if there is any question or comment from your side.
Share presentation.
Thank you, Lalit. There's really nothing much to add. I think the presentation was reasonably good. And I have nothing more to add. Thanks.
So, Dr.
Maybe I'll use this opportunity to just advise people who are looking to operate on these patients. Renals are uncommon, and cancers are far more uncommon. And what Nayak said was absolutely true. We see only about 5 to 6 patients in a year. So if you do have cancer, don't try it laparoscopically unless you really have had the experience. If you have experience, you're confident of doing an R0 resection, try it. But if you really think there's a cancer, go ahead and do an open surgery, even if it's just a 6 or 7 centimeter. Much more important to give an R0 resection than trying to show it laparoscopically. And the presentation is back up, so we can maybe proceed with that.
Right, sir. Oncological clearance is more important, right?
Far more important. So if you're reasonably confident that it's cancer, and you're unlikely to see more than 2 or 3 cases in a year, even if you're a very high volume center. So there's really not much point in trying that laparoscopically. COs are all, go ahead.
Right, sir. So, Dr. Tanvi, welcome. Please start your presentation.
Please unmute, please unmute.
Hello, am I audible now?
Yes, yes, yes.
My presentation is a case-based presentation. Actually, everything has been spoken about adrenal, starting from the benign adenomas and then Cushing's, mineralocorticoid tumors, and cone disease and pheochromocytomas. My is a case-based presentation wherein I am presenting a bilateral pheochromocytoma, which has been treated laparoscopically in our center. We have been having adrenal since last couple of years to our institution. It is also a referral institute in our state. So, but we are not getting as much as the Professor Raju is getting. But we have been having this opportunity of having at least one laparoscopic bilateral adenectomy. And thanks for North Zone for giving me this opportunity to present this. Here. So, so my slides are stuck, so I'm trying to so okay. So my case was a 34-year female patient. She came with a history of hypertension, which was uncontrolled for last 3 years, and she had pain in left upper quadrant since last 1 week. It was dull, aching, and past history, personal history, and menstrual history was not significant. So on examination, she was having tachycardia, resting tachycardia, and her BP was controlled that time. Once she came to us, because she was already on 2-3 drugs, it was 130/80. Her systemic examination was normal, nothing significant in neurological examination. Lab investigations were all normal except normetaneplasma, normetanephrines were raised. Rest everything was normal. And these are the CT images of this patient, wherein showing left side around 6 centimeter large mass, adrenal mass with central necrosis. And on right side, there is a small mass. It is around 3 centimeters, 2.5 to 3 centimeters. And these are the clear pictures. On one side, left side, bigger mass, and right side, encircled one small mass. The report was suggesting it's a bilateral pheochromocytoma. Left side 4.8 centimeter largest diameter, and on right side it was 1.5 centimeter. And these are the MRI images showing, again suggesting same light bulb sign clear on the left side. So features were suggesting a bilateral pheochromocytoma. Chemical shift MRI, and then we decided to take it for surgery after giving adequate pre-op BP control. We started with alpha blockers, and then later on added beta blockers also. And transperitoneal laparoscopic adenectomy was done. First on left side, because it was a larger mass, so we decided to do on left side first, and we did it. Later on we shifted the patient to other position and did laparoscopically on the right side. And these are few intra pictures. Nothing, special in these pictures. Just on left side followed by right side. Stuck. So this is the final picture of the ports on both sides, the left side and right side. And this is the final picture of the specimen. Left side was larger one tumor around 6 centimeters, and right side we could not make up the nodule where the nodule is. So this is the picture of whole of the adrenal. Right side adrenal. So post-operative course was uneventful. She was managed in ICU intensive care unit by endocrinologist was there, and we started the replacement, and she was discharged on around third to fourth day. Drains and catheters were out, and she is right now on the follow-up since last 1.5 months, and she is on only 50 milligrams of hydrocortisone on the follow-up. And these are the histopathology pictures showing the chromaffin cells of pheochromocytoma, typical of pheochromocytoma, nested pattern. They call it, the pathologist calls it nested pattern, and this was the report. Then literature review, bilateral pheochromocytomas occur in around 7% of the adults and 37% of pediatric age group. Patients. Genetic disease is present in around 80% of patients, predominantly Mantoux syndrome, neurofibromatosis, and VHL gene. And these are the signs and symptoms. These have been already spoken, so nothing much better, different in these. Same signs and symptoms which are present in unilateral pheo, and so these are the syndromes associated with the bilateral pheochromocytoma. We should be evaluating these syndromes, and this is the algorithm for the diagnosis. Already spoken about this. Also, I am not going into it. And perioperative medical management.
I think if there are any clinical details.
No, there are no clinical
Otherwise,
details. This was just a case.
From
Yeah. Any questions? Yeah, thank you.
Right.
These are this was a case presentation.
Right.
Thank you.
So, since this was a bilateral tumor, just a question, would you now assess for other areas of
Actually, we were
maybe
actually,
MIBG or maybe PET scan has a role here?
PET scan we already did. There was nothing in the other areas. It was actually we did MIBG scan, but DOTA scan was actually advised by our endocrinologist, which was unfortunately not available in the state, and the patient couldn't afford to go out. So we decided to go with MIBG, and PET scan we already did. So PET scan was not showing anything significant. It was not suggestive of malignancy or any other lesion in the body. So we went ahead with bilateral endectomy.
And I just have a couple of comments to make. You've done a great job.
Thank you, sir.
But you don't really need to investigate them so much. You don't need a chemical shift imaging. You don't need a washout studies. You don't need an MRI. You need all those things when you have an incidental lesion where you're not sure whether it's an adenoma or it's a malignancy or it's functional. When you're unsure, then you need chemical shift imaging on the MR, or you need the washout studies. When the tumor is clearly functional, when the blood pressure is high, the catecholamines are elevated, you know that these are functional tumors. So you can proceed without those detailed investigations. I also agree with your plan of doing the left side first. I would have done the same thing. Our principle is to do the larger size first, typically, with the hope that the catecholamine surges would be lower. But your left side tumor had a lot of necrosis in it. So there is also a possibility that the greater amount of production could have come from the right side. But nonetheless, I agree with you completely. I would have done the left side first. The port placements are slightly different from what we do from a nephrectomy. The ports will typically follow the curve of the costal margin. So the left hand, or at least that's how I work on the, for example, the right side, the left hand would go more lateral, following the curve of the subcostal line, and then the right hand would come a little more medially. So those are just minor differences. Whatever you're comfortable with is absolutely fine. And as long as the outcome is good, it doesn't matter where you put the port. At the end of the
Thank
day,
you, sir.
if the tumor is out, it's a great job done.
Thank you, sir.
Thank you. Now we move to our last section, that is surgical approaches. I want to welcome our chairpersons of this session, Professor Amlesh sir, Dr. Atul Kumar Mittal, Dr. Salim Mani sir, Dr. Safiq Ahmed, and Dr. Shiv Charan. So without wasting time, we go to our first talk, that is surgical management of adrenal mass, open versus lap adrenalectomy, SKIMS experience, by Dr. Saqib Mehdi. Dr. Shakib, are you ready?
Yeah, but I think it's not getting shared. So I think if meanwhile Dr. Javed Qadri.
Meanwhile, I think Dr. Syed Javed Qadri can present if his slides are ready. Right.
Yeah, my slides are ready, sir.
It's not happening.
Are my slides visible?
Yes, sir. Slides are visible.
Is it okay?
Yes, sir, it's fine.
Yeah, good evening to all the people who are connected with us. And first, a great thank you from my side to the North Zoom, especially for considering me and especially for my state for considering my state. We have been discussing and hearing a lot about the adrenectomy, and we will take to a different sphere in this presentation. My presentation is an operative procedure dance. There is no theory business in this presentation. So we will doing how we are addressing these tumors through a different way, that is through a retroperitoneal way. We as urologists all know what are the advantages of operating an urological organ retroperitoneally. So we are always comfortable with it. But somehow most of the people approach adrenal through a transperitoneal route. But I myself routinely approach this organ retroperitoneally. So this is one of the common things which we face in our daily busy urological practice. There is a tumor in adrenal, and in this case, in this patient, we had a mass of 5.5 into 3.8 into 5.2 centimeters. This was not a CT scan which was done for and with an adrenal protocol, but this CT was with the patient once who visited us. So there are no washout indicators in this, and the patient has a contrast enhancing lesion with irregular contrast enhancement. We did a standard functional workup, which was negative. So we had always something in mind whether it is a carcinoma or not. All the indicators of carcinoma were absent, like necrosis, irregular margins, local lymphadenopathy, or through tumor thrombus. But only one thing which was in our mind was that there is some irregular contrast enhancement. So the surgical intervention was planned because the lesion was more than 4 centimeter, and then we decided that we have to operate this. So the procedure which we chose was a retroperitoneal laparoscopic adrenalectomy. So is my slide going on the? Hello? Hello?
Yes, sir. Your slide is visible. Are you going to show any video or
Yeah,
something?
definitely.
Yes.
So
Yes,
this is the
now your slide is visible.
yeah,
Right.
yeah. This is the patient which is positioned in the left lateral decubitus position. To do a retroperitoneal laparoscopic adrenectomy, we need to palpate the lower border of the lowermost rib and the erector spinae muscles. These are the most common sites which we choose for putting our ports. And usually every retroperitoneal surgery has two parts. One is to develop a good retroperitoneal access and then to address that organ. So this is the first incision which are made just below the tip of the 12th rib. In this step, we usually try to do everything under vision. So we'll be dividing the musculo-aponeurotic layer at this point under vision so that we get access into the retroperitoneal space. First, you can see these are the muscles which we are cutting, and then we are able to see this opening in the fascia. The most important thing which we have to do at this point is that we have to confirm that we are exactly in the retroperitoneal space. And the thing by which we would confirm is by seeing this yellow paranephric factor. This tells us we are in the space. Now, the second point is how to develop the space. We are using a dissector to develop some space actually for putting the balloon. So this is a space which you can see, which we have done after doing some peanut dissection. And this is the most common balloon which we are making on table for doing the dissection. So now the balloon is placed behind the upper pole of the right kidney so that a space develops at the upper pole. So now the coordination will be done by two persons. I am myself just pushing this normal saline, and another person is trying to coordinate with me. So usually around 500 to 600 ml of saline is put in the balloon so that a space develops behind the kidney. So once we have done it, then we wait for 1 or 2 minutes because this helps us in the hemostasis. Sometimes small vessels are teared up by the shearing force of the distended balloon. So now we are decompressing this balloon, connecting it to a suction. So now the balloon will be completely decompressed. The saline is being drained out. So after this, we are confirming that the balloon has not ruptured inside. And the next point is fixing the first trocar. This will be a 10 mm trocar cannula for good vision. And at this point, we should try to fix all the muscle layers at this point so that there is no leak of the carbon dioxide. we usually take a vertical mattress suture, a pulley type at this point, and then we place a 10 mm cannula. You can note that there is no trocar at this point because usually trocars are having very sharp points and they can injure the retroperitoneal structures. Just note at this point, we will not be fixing this cannula. We're only trying to tighten it. We are not fixing this cannula. The point at which we have to fix this cannula will be done under vision. So how we are going to do it now, we are putting a telescope inside. We don't want this cannula to be too deep inside the retroperitoneal space. We want it to be at the edge, exactly where the muscles end. So you can see we're pulling it back, and this is the point where we'll stop. We'll just introduce 2 or 3 mm inside the retroperitoneum. And this is how we fix the 3 trocars in the right side adenectomy. You can note one thing, that the 10 mm trocar is at the renal angle because we're using the clip through it. So now we are starting the procedure. The first layer which you are seeing is the paranephric fat. There's a message for my juniors who will be contemplating to do retroperitoneal surgeries. Now I try to open the renal fascia through this fat. This is going to disturb you. The blood drops are going to come into your field and you will be having a difficult time. So at this point, what you have to do is you have to just remove this paranephric fat. So take time, do a very clean dissection and remove this paranephric fat. And the glistening layer which you are seeing posteriorly is the renal fascia, the gyrotous fascia. Now you have to open up this gyrotous fascia by making an incision parallel to the psoas muscle. So if you are parallel to the psoas muscles, you have no issue with respect to injuring any of the structures. So this is how we are opening the gyrotous fascia. Since now our target is to reach the adrenal, we are going to excise the perinephric fat. So once we remove the perinephric fat, with any type of energy you are having, it can be a diathermy, it can be harmonic, ligation, whatever you are having. So try to reach the upper pole of the kidney. So this is once we have removed the whole fat, this is a lesion in front of you. So we all know on the right side, we are always focusing on the renal vein. So now we have to do a very delicate, meticulous dissection. Actually, I love this instrument. It is a hook electrode. This acts as a cutter, dissector, coagulator, whatever you like. You should at this point have to retract the tumor superiorly towards the 12 o'clock position. And then you will be seeing the renal disc, the IVC, and the adrenal vein. So at this point, adrenal vein is at a distance from you. It is at the upper border IVC. And this is once we are dissecting the right-sided adrenal vein. So the IVC is flat horizontal and the adrenal vein is coming at the 12 o'clock. So this is how you dissect the adrenal vein. You need to be very much gentle at this step. The another advantage at this step in the retroperitoneal surgery is if you have some bleeding at this point, you don't need to worry. You simply have to increase the pressures in the retroperitoneum and you can have some amount of hemostasis till you close that opening. So using the angle dissector, this is a adrenal vein. So now I have to take the clips and these clips are coming from the renal angle. So this is my non-dominant hand. This is the left hand I'm using for clipping on the right side. So 2 clips towards the IVC side and 1 clip towards the tumor side. So after this, we have to divide this vein. So I always prefer using a scissors to divide it. So this is the renal, this is the adrenal vein which has been divided. So cysts always have adrenal have the potential to be malignant in the postoperative histopathological evaluation. At this point, now the adrenal surgeon focuses that there should not be any breach in the capsule. So I have to try to get a R0 resection, which should be the aim of all adrenal surgeons. Never breach the capsule. So at this point, I'm again being helped by the hook dissector to remove this adrenal tumor. You can see I can peel off this tumor from the surrounding tissues. And I am using a thunderbeat for dividing tissue which is vascular. And this is how the tumor has been circumferentially dissected from its tissues. Now there's always a parking space in the retroperitoneum. This is a space which is between the abdominal wall and the renal fascia. I am parking the tumor in that space and then confirming the hemostasis. You can see where is a place for adrenal vein and you can see the IVC posterior to the liver. So usually I never place a drain because hemostasis is 100% on table, very ensure. And since always had that is patient maybe a malignant lesion, I'm using an endo bag to retrieve the specimen from the inside. So now this specimen is removed, retrieved from one of the port sites. And this is how we complete our retroperitoneal laparoscopic adrenalectomy. And what was our suspicion that came out to be true on histopathological analysis, this patient had an adrenal cortical carcinoma. The margins were free, the R0 resection, but the patient had tumor invasion into the capsule. So this patient received an adjuvant treatment. So now I just want to draw your attention what are the advantages of retroperitoneal. Since you have watched this video, you should believe in this procedure, and adrenalectomy can be done laparoscopy through a retroperitoneal approach. Since we all do transperitoneal procedure, you can see we always have complications of access to the peritoneal cavity if you're transperitoneal. But in retroperitoneal, you don't face these complications. You don't waste time in mobilizing the bowel in a retroperitoneal approach. Your previous abdominal surgeries do not affect the retroperitoneal approach. Venous bleeding can be easily controlled by increasing the CO2 pressures. It has a short operative time as compared to a transperitoneal lap procedure. No post-operative shoulder pain because you are not inducing retroperitoneal, just pneumoperitoneum. No issue of post-operative ELS, short hospital stay, no long-term complications of bowel adhesions and associated morbidity. So we all as surgeons have to keep learning and keep growing. So all urologists who are doing only transperitoneal adnectomy, I request them to go in the retroperitoneum, start at retroperitoneal laparoscopic procedures, and you can even do adnectomies. And those urologists who are already doing a retroperitoneal lap procedure, they should also do a laparoscopic retroperitoneal adnectomies also. It is really a rewarding procedure. So with this, I thank all of you.
Thank you, sir. You have done beautifully. Retroperitoneoscopic adrenalectomy. It was a bloodless surgery. We all agree with the advantages of retroperitoneal surgeries. Any questions from Srinagar Hall or from chairpersons?
It's a very, very nicely demonstrated procedure, very elegantly displayed, Dr. Kadri.
Thank you so much. Thank you.
Just maybe adding that the tumors which have a retrocaval limb of the adenoma, the retrocaval part is very easily dissected from this retroperitoneoscopic approach. So all those tumors which have that retrocaval component may preferably be actually be treated retroperitoneoscopically.
Yeah, definitely. Actually, it is that scare of the unknown which inhibits most of the laparoscopic surgeons not to do retroperitoneally. But once you start your doing, you will see what are the advantages. You are very advantages for the surgeon, for the patient, and for the operative time.
Right, so one query, just small query.
Yes.
What about the lymph node dissections if adrenocortical carcinoma is there?
The point is, if you have a preoperative imaging, when there is a suspicion
Then
of
we-
then the procedure will be transported. Then it will not be a retroperitoneal procedure.
Right. So now we move
Dr.
to
Javed, Dr. Javed, a nice presentation. I compliment you for a nice presentation. Everyone knows how difficult the retroperitoneal surgery is. And you are using the classical DD-GOR balloon. Have you tried or used the ballooned trocars for this thing, or you are comfortable with the DD-GOR balloon which we classically
Sir,
use?
actually, if you have to move from one place to other place, you would like to have a Mercedes Benz, but at the same time, you can do a Maruti can do the same job. In our
Exactly.
place where we are very limited resources to make a DD-GOR balloon on table takes 1 minute, saves the price and but does the same job.
Yes,
So I have
a
never
nice
used it.
presentation.
I have seen. Thank you so much, sir.
Yes,
Thank
a
you.
nice
Thank you.
presentation. Nice
I must
presentation.
congratulate. Very nice presentation. Just one point of technique. And if you don't use a Gore balloon, once you have reached into the retroperitoneum, by air pressure itself, you are making a dissection. Because your air is going in the direction and you are dissecting. Gradually, you can make it.
Yeah, that is true. But that happens once you have some amount of space to work upon.
Yes, true.
So if you have to start
Creation of space.
with creating of only CO2, that is difficult. So once you have some amount of space, then you can move with the air pressure by doing the dissection. Your point is well taken, sir.
Right. So next speaker is Dr. Saqib Mehdi. He will be talking on surgical management of adrenal mass. open versus lap adrenalectomy SKIMS experience. Right.
Good evening, everyone, and apologies for the delay. I am Saqib Mehdi, Assistant Professor at the Department of Urology, SKIM Srinagar, and I will try to briefly summarize our experience regarding the surgical management of adrenal masses over the past 3 years, wherein we have operated about 28 patients with adrenal masses who had a slight female preponderance, and we had a case of bilateral pheochromocytoma in whom we did open bilateral adrenalectomy. 4 of our patients had concomitant malignancies. One had a lung malignancy, which was diagnosed by biopsy, and 3 had concomitant renal masses, 2 of which underwent radical nephrectomy, and in one of the patients, we had to do a nephron-sparing surgery. 15 of the patients on pre-op evaluation had functioning tumors. On final histopathological examination, pheochromocytoma was the most common diagnosis, and we had adrenocortical carcinoma in one of our patients. Initially, we had been doing open adrenalectomy, but gradually we have shifted to laparoscopic adrenalectomy. We still continue to do it in larger masses greater than 5 centimeters, and we had a single case of adrenocortical carcinoma in whom we did an open adrenalectomy. So we had a 55-year-old female who had a right suprarenal mass preoperatively suggestive of pheochromocytoma. You can see the imaging, and there was approximately a 4-centimeter mass in the right suprarenal region. This was the port position. We placed a 12 mm camera port in the umbilical region. Then this was the left port along the subcostal margin. This is the right port, 10 mm. And this again, one more 5 mm port we have placed for retraction of the liver. I will be playing a short video to demonstrate adrenalectomy, right laparoscopic transperitoneal adrenalectomy. All the cases we do there are transperitoneal adrenalectomies. We don't do retroperitoneoscopy. So most of the cases are done where transperitoneal approach. This is the right lobe of the liver being mobilized, and this presumably is the upper pole of the liver. We're trying to mobilize the right lobe of the liver so that we can retract it superiorly and get a better exposure of the adrenal gland. This is the liver being retracted, and this is the minimal mobilization of the colon. Now we are trying to carry out. We don't mobilize the entire colon as we do in a radical nephrectomy. And this is almost, we have exposed the adrenal gland between the liver and the upper pole of the kidney. We're trying to enter the gerotus fascia and separate the adrenal. We are working in the perirenal fat and separate it from the upper pole of the kidney. We'll be trying to extend it laterally, and then we have come over medially. You can see the inferior vena cava. We're trying to enter the gerotus fascia there and create a plane between the inferior vena cava and the adrenal. This is the space being created between the IVC and the adrenal gland. The adrenal vein has become visible. We'll be allowed to use the hook to carry out further dissection and exposing the vascular structures. We'll further mobilize the adrenal gland, and you can see as we walk along the superior aspect of the adrenal gland. Walking all along the adrenal, and then we'll laterally separate it laterally. And this is perforating the adrenal laterally. The liver has come down. We'll be retracting it again after further mobilization. And trying to lift the adrenal. We have clipped some small vessels over there, and these are the adrenal arterial supply of the adrenal glands that is being clipped, and then we'll be dividing it further. I'll try to denude the adrenal vein using a hook. And this is the adrenal vein. Define it circumferentially, and then we'll clip the adrenal vein. We clipped it doubly, and this is the adrenal vein be divided. These are the remaining attachments of the adrenal gland that have been freed. So finally, it's being separated from the upper pole of the kidney. I'll be forwarding the video to cut it short. And we put it in an endo bag to retrieve it. So the patient had a smooth post-operative course and some follow-up. Next, I'll be presenting a small few slides regarding a patient who had adrenocortical carcinoma. She was a young female who presented with left flank pain and features of hormonal excess, and this was a pre-op evaluation. There was a large mass which on CT was approximately 15 centimeters. You can see the imaging. These are the coronal and the axial cuts of the same patient, and we contemplated on a left open adrenalectomy. She also had an IVC thrombus. That was a bland thrombus. We did a left adrenalectomy open approach. This is the tumor in the intraoperative pictures. The patient received adjuvant radiation therapy to the tumor bed and had a smooth post-operative course. She is in follow-up. This was the imaging that was 9 weeks later. She had a residual small collection in the perinephric area and reactionary pleural effusion on the left side. This was the preoperative image of the patient. She had hirsutism and other features of hormonal excess. And this was her final picture after the surgery was done. And that's all. Thank you very much.
Any questions from the chairpersons? Dr. Salim?
Yes, Dr. Sakib Mehdi, nice presentation. Congratulations, doing wonderful job. I just need to ask about this adrenocortical carcinoma case. Did the imaging show you anything about the lymph nodes or the involvement of the surrounding structures, and what was done? Did you do the lymph node dissection in this patient?
So it was a large mass. It was adherent to the transverse mesocolon, but not grossly macroscopically infiltrating into it. Imaging preoperatively, although lymph nodes were not visible on imaging, but there was a bland thrombus was extending from the renal vein along the left renal vein into the IVC. But other than that, sir, no other lymph nodes were visible, and we did an open approach, although a pre-op biopsy was also done that confirmed the diagnosis. And but post-operatively, intraoperatively, we could not, any lymph nodes were not visible, but there was a huge mass. It was adherent to the transverse mesocolon, and other than that, because it was a large mass infiltrating into the capsule, and she deserved adjuvant radiation therapy.
Yes, obviously for such huge tumors, the open procedures are recommended other than the laparoscopy. Good, nice job. Thank you.
Dr. Atul?
Nice, nice job, nice demonstration of the cases. I had a very good learning today. Thank you. Thanks a lot.
Thank you, sir. Thank you. With this, we come towards the end of our program. But before we conclude, I'll like to take comments from Dr. Arif Hamid also, who is currently heading the Department of Urology at SKIMS, the largest hospital in Srinagar. Dr. Arif.
Yeah. Thank you, Dr. Rishi. And being a part of this program, I take this opportunity to thank all the participants, the chairpersons, the presenters, all of them, and making this happen. And also, I'm very happy to see participants and presenters from our part, Jammu and Kashmir, presenting, showcasing their work. And what's heartening is to see all our seniors still actively participating, sharing their experiences, and giving us tips in managing these patients. And I really compliment the North Zone Council, Dr. Sanwal, Dr. Rishi, Dr. Lalit, for making this program and discussing this topic, which is not very frequently discussed, as Dr. S.K. Singh said. And we all of us learned about the symptomatology, the investigative part, the medical management, and so many varied these presentations. I think it has been a very fruitful discussion, and I'm sure all of us have learned from these discussions and sharing each other's knowledge. Thank you all, one and all. Thank you.
Thank you. Thank you, sir. this initiative of North Zone Showcase State is actually to bring the states which we may not be frequently visiting or may not become part of our programs on a bigger front, and probably doing these kind of programs more often will come closer to each other, and ultimately maybe all state societies would also come under the umbrella of North Zone. Right now, each of us are working independently. Anyhow, working on this program was a delightful experience. All three major institutes in the Jammu and Kashmir state, it is still a state for us, have come together. GMC Srinagar, Dr. Sajjad, when we floated the idea, he immediately agreed. Then Dr. Elia Sharma, Dr. Rahul Gupta also agreed. And then I talked to Dr. Arif Ahmed also. He also immediately agreed to this idea, and we all could come together only because of this unity and work in unison with each other. So thank you all the departments to have accepted our request and have worked with us. Thank you once again. Dr. Sanwal, if you have final comments.
Thank you, everybody. Besides, with these programs, we come to know such wonderful talent. Like retroperitoneal laparoscopy approach is not very popular. Majority of urologists are doing intraperitoneal. So nice and meticulous dissection he has done. So we come to know the persons who are doing in remote such a good work in remote corner of our North Zone. So we will like to him to show more and more in such demonstrations in our bigger stages. So with that way, we will keep on doing such programs in future also, and as we get the input. And Dr. S.K. Singh, sir, you want to say something? Thanks everybody.
Thank you, sir. Thank you for having us involved. Thank you.
Thank you. Thank you.
Thank you all. Thank you very much. Very nice. Well done.
Good evening to everybody and happy.
Bye. Bye. Good night.
Thank you so much. Thank you, everyone, especially all the persons who
Thank
are
you,
present
Rishi.
in the hall and all the attendees who attended the webinar. Right. Thanks to all the chairpersons and the speakers.
Lalit has done wonderful job.
Thank you,
Congratulations.
sir. Thank you so much, sir. Thanks to one and all. Thank you so much. We will be in touch and we'll be keeping further activities. Right. Thank you. Thank you so much.
Good night.
Good night, everyone. Good night.